Hello, 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 hello.
Welcome you all here. We have here our own President Sir, Dr. Bhora, our Secretary Sir, Dr. Karamjit Singh, very senior dignitaries like Dr. Ten, Dr. KD, and I also thank Madam Mrs. Bhora, who had been our past President, Dr. Mr. Sangha, and so many other dignitaries. And I really appreciate the efforts made by the Ophthalmological Society, who has been I would say, the last child of POS Ophthalmic Society, who has the district which has associated with POS, but they are doing so well, and they have now shown that they are the forerunners in this monthly meet by conducting the first monthly meet of this year. So, not taking much of time, I would like to just Our President, Sir Dr. Bhora, has given us the responsibility of conducting various academic activities throughout Punjab. And for this, he has formed this boss of the scientific committee. I have been given the responsibility of being the chairperson of this society, and after Dr. Rohit Om Prakash. And now it's like a huge shoes, I would say, whom I need to fit in. And I have very prominent members with me. Rather than conducting these meetings only in the larger cities, tried again, and the bus, the observations can
A very good morning to you all. Thank you very much, Dr. Raman, Dr. Balwinder. Now, I would like to invite Dr. Karandeep Rishi to speak a few words about the role of laser photocoagulation in the era of anti-VEGF. Dr. Karandeep.
इसके ऊपर ही रख के ना इसको लगा लो HDMI है ना इसमें हाँ जी हाँ जी इसमें
What is the role of lasers? उस पे presentation कर What is the role of lasers in diabetic macular edema? In 1991, the ETDRS study established the gold standard as macular grade for any patient having CSME, that is clinically significant macular edema. And it showed that it reduces the risk of moderate vision loss by about 50%. And since then, it is the gold standard against which all the newer treatments have been compared to since then. How it acts? The focal laser acts by direct occlusion of the lumen of microaneurysms, and the grid photocoagulation, it acts by various mechanisms. The brief thing is that it increases the oxygen supply to the remaining retina so that they can function better. The various studies which compared laser monotherapy with others include, first is Protocol B study, which compared triamcinolone with the laser monotherapy. And it found that at 1 year, there was no significant difference between laser and the triamcinolone group. But as the time increased, the laser was better than the triamcinolone. This was thought to be due to cataract development in triamcinolone group. In 2010, BOLD study clearly documented the beneficial effect of anti-VEGFs compared to laser. We were not just stabilizing the vision, but we were also gaining more and more letters. Bevacizumab group was able to achieve gain of +8 letters at 12 months, and at 2 years it was +9 letters. So we were talking of improvement here. In aflibercept study, it was found that the improvement was more marked than the Avastin group. This was clearly established that 30 to 38% patient gained more than 3 lines with the help of aflibercept in macular edema patients. So this is the summary of various studies which were conducted. I will be highlighting the role of laser in these studies. We know that in ETDRS, about 17% patients gained 1 line of vision due to laser in taking care of diabetic macular edema. In Protocol B, I already talked, laser was found superior to triamcinolone. In Protocol I, it was found that about 28% of focal laser alone group still gained 2 lines of vision. And the good thing about laser was the effect of anti-VEGF was decreasing with time, but the effect of lasers were improving with time, and it continued to improve after 4 months. In Protocol T, we will find that about 50% of the patients after receiving various anti-VEGFs still required laser so that their vision could be stabilized. And it was found that the laser was able to decrease the number of injections. So, in brief, anti-VEGFs are the preferred and most effective treatment in DME in ideal study conditions, but lasers have a long-term, slow onset effect. So what is the present role of lasers? It is used as a combination therapy to decrease the number of injections. It is used as a rescue treatment for non-responsive or poorly responding patients, in non-compliant patients, in non-center involving diabetic macular edema, and in non-affording patients. Lasers are used in first-line therapy in DME in following cases, like in non-center involving DME, when the central DME patient presents with good vision at baseline, or patients with recent history of cardiovascular event or CVA, then we prefer to avoid anti-VEGFs, and patients who decline intravitreal injections. In pregnancy, anti-VEGFs are contraindicated, then laser is the first line of therapy. Nowadays, there is a concept of combination therapy. First, we give intravitreal and anti-VEGF, and then we do laser. So why it is so? Because anti-VEGF acts immediately and it decreases the edema, but they are cleared from the system, so the effect is short-lasting. But laser is permanent, and it is a long-lasting effect, and its effect starts after 3 months of radiation. So combination therapy helps in persistent reduction in macular edema after the effects of anti-VEGF drugs has been attenuated. So why anti-VEGF should be given before laser? Because laser under a thickened retina will need more energy, and it will cause collateral damage to the retinal tissue. Laser therapy after anti-VEGF, it may need multiple anti-VEGF till vision improvement or reduction in CME stops. We continue to give anti-VEGF injections until the improvement occurs, and after that we can do laser when the maximum vision has been achieved. It will require lower laser energy, and it will help in maintaining improvement of vision. Lasers decrease the number of injections compared with monotherapy. 84 they act at the inflammatory level. The anti-VEGFs, they neutralize the VEGF molecule, and the laser acts at the effect of VEGF. That is, the breakdown of blood retinal barrier and vascular permeability is treated with the help of laser. So in real world, diabetic patients have other problems also, like neuropathy, nephropathy, and they have other needs of social and occupational needs, and they are unable to attend retina clinic regularly. Many patients need dialysis, they are not very compliant to the treatment. Studies shows that missed appointment rate for diabetic patients is more than 40%, and in DRCR protocol, 8 to 9 injections were given per year, and in protocol T, 15 to 16 injections were given in 2 years. But in the real world, hardly patients get 2 to 3 injections in a year. So compliance is very important. Less than 1/3 of patients with newly diagnosed diabetic macular edema actually received 3 or more injections in the first 4 months of after diagnosis. So compliance is more important in anti-VEGFs, more important than in lasers, because the effect of laser is going to increase with time, and the effect of anti-VEGFs is going to wash out with time. So untoward outcomes in the face of non-compliance should be clearly explained to the patients with the help of fundus photographs. For a less compliant patient, it is better to do laser rather than anti-VEGFs, because lasers are more forgiving. In non-center involving DME with obvious leaking microaneurysm, we can just laser this part of the microaneurysm, and the edema will resolve spontaneously. So what are the benefits of doing focal laser? It decreases the cost, there is less chances of endophthalmitis, less pain, less transient blurring of vision after injections, less risk of injury to various structures of the eye, and less chances of sudden worsening due to non-compliance. So if there is recent history of cardiac event, then also in pregnant patient, we have to avoid anti-VEGFs and do laser. Nowadays, there is a concept of targeted retinal photocoagulation, because we know that the site of cytokine production is the area of partial ischemia. This partial ischemia, here the cells are dying. They produce various cytokines, and VEGF is produced from this area. So this area is targeted in laser. This complete ischemia, already cells are dead. This is not the site of production of VEGF. The site of production is here. If we target this area during laser, that decreases the load of various VEGF molecules, and it helps in treating patients in the long term. So this is the complete CNP area. This is the partial ischemic area. So this area should be targeted also during laser therapy. So focal laser of DME is not dead. It is practical, effective, evidence-based, and cost-effective approach. Now coming to the role of lasers in PDR. In 1971, DRS study clearly established that the severe vision loss in patients with PDR with high-risk characteristics is decreased by 50%. And since then, PRP has become the gold standard for treatment of PDR. But recently, Protocol S study challenged this view and told that ranibizumab is non-inferior to PRP. In fact, it is better than PRP in preserving vision or requiring less vitrectomy patients. There was less of DME in the ranibizumab group. So, what is the conclusion for today for PDR patient? Whenever there is center involving DME, we should give anti-VEGF and then followed by laser. If there is non-center involving DME, that means that macular edema is there, but the center is spared, then also preferably anti-VEGF followed by laser, because whenever we do laser, there may be increase in macular edema, which can be taken care of pre-op anti-VEGF. If there is no DME, then we can counsel the patient for both PRP or anti-VEGF. Anti-VEGF can be offered because it will need multiple injections till the new vascularization is stabilized for about 3 to 4 visits. Anti-VEGF group has greater visual acuity, less visual field reduction, less chances of DME, need for vitrectomy, but is invasive, needs compliance, and there is risk of endophthalmitis also. Nowadays, there is a concept of angiofibrotic switch. Whenever we give anti-VEGF, we are just neutralizing the VEGF molecule. The other inflammatory molecules like CTGF, they continue to act, which leads to fibrosis and scarring, which may lead to traction and blindness. Here you can see new vascularization, which was treated with anti-VEGF, and you can see the fibrosis, this white thing, fibrosis, gliotic tissue. This in Bravo study, they concluded that anti-VEGFs are better in decreasing the edema, and there was gain of vision in more than 50% of patients. More than 3 lines of gain of vision was there. So since then, anti-VEGFs have become the main treatment of treatment for the BRVO patients. So what is the current use of lasers in BRVO? It decreases the number of multiple injections when used in combination with anti-VEGFs, and it is used when new vessels develop. What is the role of laser in CRVO? CVOS study spotted the role of laser in new vessels only. There was no role in macular edema due to CRVO because macular grade laser was not effective in these patients. So peripheral field of vision is very important in CRVO because there is already a macular scotoma. So we should not do any prophylactic PRP. We should avoid PRP till NVI or NVD develop. In CRUISE study, it was again found that anti-VEGF is very good in improving vision in CRVO patients. Now coming to the role of lasers in CSR. CSR anti-VEGFs are not proven. Whenever there is a leak, FA should be done and should be lasered. Other rare indications where laser is better, one is circumscribed choroidal hemangioma. This can be diagnosed clinically or on FA. Adult onset Coats disease, FEVR, when we find it in early stage before RD occurs. Vitreous hemorrhage caused by retinal breaks. Obviously, there is no role of anti-VEGF in such a patient. Whenever there is vitreous hemorrhage, we have to look for periphery for localizing any retinal break and treat those. And extrafoveal IPCV, which is known to respond very well to laser. Now there is a new term called subthreshold laser. What is this? Here the RP cells are just stimulated or affected by, but not killed by laser exposure. How does that happen? Whenever there is laser focused on the RP cells, there is thermal activation of heat shock proteins. Heat shock proteins are present in many mammalian cells and even prokaryotes, which help to regulate the function of the intracellular components. And it repairs the odd things which happen due to diabetic retinopathy. So there is a defined therapeutic range, which is the zone where the treatment is effective, but it is not lethal to the retina. Its safety is maximized by use of longer wavelengths like 577 or 810 nanometer wavelength. The longer interpulse duration, so that there is a cooling period between the pulses of laser, and low frequency of pulse trains. It is said that even transfoveal treatment is safe. They are doing pan-macular treatment with 5% duty cycle with 200 millisecond pulse duration. It means that 5% of 200 is the active part of the laser and the rest is just the cooling part. And 150 to 200 micron spot size with no spacing between. Throughout the macula it is done. For diabetic macular edema and CS are the two main indications for which subthreshold laser has been used. And pan-macular treatment with 125 micron spot requires 2000 shots, with 500 micron spot just requires 400 to 450 shots. And it is shown in various studies that it improves the vision and there is very less need of anti-VEGF, or in refractory DME, it is very effective. Now coming to the types of various laser delivery systems like conventional, multi-spot and navigated. So how does it matter whether it is a conventional system or multi-spot laser? How does it help to have a multi-spot laser system? The main thing is the duration of a pulse is 100 to 200 millisecond in conventional laser system, but it is decreased to 10 to 30 millisecond in multi-spot laser. So we have to compensatory increase the power. If we are using 10 millisecond, we have to use 200 to 300 watt of power. But in 100, we can even do at 150 milliwatt of power. So the time taken for laser is less in this multi-spot. It is less than 1/3 of the conventional laser system. The pain is less in this multi-spot. Why? Because there is less thermal diffusion. The heat buildup is very less, so there is less. It is less painful. In normal conventional PRP, we might need 3 to 4 sessions. So compliance is again important for the patients. But in multi-spot laser, we can do it in just one sitting. There is less collateral tissue damage, less fibrosis, less DME. So even studies have proven that if it is done in one sitting, the diabetic macular edema is not more than we are doing in 3 sittings with a conventional laser. Then this is the conventional laser. This is the Pascal laser, which is actually a multi-spot laser. And here the heat is just localized to the outer part of the retina, and the inner layers are spared. It is photostimulation rather than photocoagulation. This is the latest thing in retinal lasers. It is called navigated retinal laser. It is just not available in India yet. And it is actually like LASIK, the eye. So when there is pachychoroid and there are polyps in the choroid which are visible on ICG angiography, then we might need to do anti-VEGFs before laser.
I think one important thing, the role of laser in ROP, that is very clear
Yes.
and
Yes,
definitive.
Yes, sir.
That is very true. Although, yes, you are right that there is a definite role of laser in the current era of anti-VEGF, but anti-VEGFs are still the first choice treatment in center involving DME.
Definitely, sir.
Although the combination therapy is quite in vogue.
Yes.
Thank you, Dr. Rishi. Now I invite Dr. H. Mitra from Phagwara. He will give a talk on management of hard cataract.
स्टार्ट आप करना ना, यहाँ से प्ले करना, यहीं से स्टार्ट है, यहाँ से एक बार क्लिक कर दोगे ना, फिर स्टार्ट हो जाएगी, स्टॉप करना, फिर बेस ये बस एरोज के ऊपर ही रखो.
Good morning, everyone. See, I am going to discuss with you how to manage intumescent cataracts. As we all know, the most common complication in intumescent cataract is extension of the rhexis, so which is called Argentinian flap. So everyone has his own way of tackling this problem. The main cause is there is a rib force which acts linearly. The moment we give cut, it extends and you find no time to restore or to bring it back. The way I am treating this, I am just going to show you the video. I am trying to dilute the effect of this rib force by giving multiple nicks in the center in very short time, so that the effect of this rib force is divided into different directions and it doesn't extend. See, I am doing it for the last couple of years with very good results. So let's see the video. So this is how I give multiple nicks. I'll just then the rest of the case I think it's same. The main problem in such cases is just to make a axis. This case was done by my son 2 years back, Dr. Akshay, and presented in APAO Indonesia. This video was selected over there. So, thank you very much. This was all.
Thank you, Dr. Mitra. It reminds me of my great teacher, Dr. Daljit Singh's technique. He used to do can opener capsulotomy in all cases, and we never saw rexes extending. Thank you.
Now I would like to invite Dr. Sahil Jain to give his presentation regarding pars plana vitrectomy for dislocated iris claw eye.
Hello, good morning everyone. On the onset, a very good video, excellent presentation, Dr. Mitra. Thank you for showing such a great video in such a short time. But I have a point here that we all have an anterior segment OCT with us, and if you are not used to using it, anterior segment OCT will delineate cases where you will have Argentinian flag and where you will not. I want to impress that OCT will tell you about the fluid.
Is a big IOL, 5 mm optic with 8.5 mm length. It is a biconvex IOL. It's large optic with looped haptics. So it's not like a normal IOL which dislocates and we take it out, explant it during vitrectomy. It's slightly cumbersome. The groove in the haptic can cause retinal tear if IOL dislocates. And it is difficult to pick up this IOL with the IOL forceps, routine IOL forceps, due to increased width at the optic haptic junction. So for the surgeons who are doing retrofixated iris claw IOL or are beginning to do that, and they don't have a posterior VR support with them, I'll advise to do more so an anterior-fixated technique, because once the IOL straightens up in the vitreous cavity, it's very difficult for IOL to bring back to the pupillary surface. So coming to the case, it was an 83-year-old female with a history of left eye decreased vision since 5 days. She had a history of cataract surgeries 5 days back, and her uncorrected vision was counting finger close to face, which improved to 6/24 with pinhole. So this is the intraoperative picture. We can see the iris claw. It's attached at one point, and it's in the pupillary plane as of now, but it will be hanging, we will see in the video. And the iris is also atrophic. So she had an aphakia with a dislocated iris claw with 1 point capture and nucleus fragment drop in vitreous cavity. So a PPV with iris claw IL explant, nucleus removal and SFIL during under LA was planned. For this patient, we planned explant because this patient was experiencing swishing effects of the iris claw, and she herself wanted to remove this iris claw, this IOL. Even she requested us to leave her aphakic if another IOL is not possible for her. So coming to the surgery. So it is a routine surgery with a conjunctival peritomy and making of the scleral flaps at 3 and 9 o'clock with the help of crescent knife and one is scissors. So this is the hanging iris claw. Core vitrectomy was done, followed by a PVD induction. Once it was completed, we did peripheral vitrectomy around the IOL to free the IOL of any residual vitreous which is encapsulating it. A complete peripheral vitrectomy was done. Then we addressed the nucleus fragment part. Which was removed subsequently. This is the nucleus. After doing so, I tried to untuck the IOL going behind through the posterior approach, but the iris claw was not disengaging from the iris at this point of time. So we changed the approach and tried to untuck it using a second instrument from the anterior side through the limbus, but I was unable to do so. It was very firmly adherent with the iris. So I had no option but to sacrifice the iris. We could have even used a cautery to get free hold of the IOL here. But to my surprise, the IOL went down. And now you can see here that there is a small brush right at where the groove is, just below the inferior arcade, which is called a retinal tear. Now I tried to pick it up with the routine intraocular forceps, but I realized that the width at the optic haptic junction is too big to catch hold of it. And secondly, it is slightly flat on the retinal surface, not providing me with the distance to pick it up. So I put a PFCL and I changed my approach. I used the active extrusion on the machine, which is actually active suction. And I pick up the IOL with the help of active suction, and I pick it up horizontally. Because if I pick it up vertically, then there is again a chance of a retinal tear. And then suturing the IOL underneath the scleral flaps. And similarly on the other side. So this is well-centered steel fixated IOL, and here we complete the surgery. Thank you so much for listening to my talk.
nicely presented, Dr. Sahil.
Thank you, sir.
Anybody from the audience? Any questions?
A lot of these iris claw IOLs led to corneal decompensation done 20, 30 years back by Dr. Daljeet Singh. And having to treat the endothelial transplant, I had the opportunity to remove a lot of these iris claw. What I felt was if you're not able to disenclave it, another option is the claws are very thin, though they are PMMA, but they're very thin. Instead of sacrificing or cutting the iris, you can just cut the claw. With Vanna's Caesar, especially through a 4 mm incision, you can easily cut the claw. To remove the IOL, instead of cutting iris, I would prefer to cut the claw.
That's what we thought, but there are two things here. First, if it is anterior-fixated, then the iris, then the loops don't give us a problem. When they are behind the iris, and the iris is kind of a floppy in this patient, as you saw. So these loops can create a retinal tear later on, which has happened with many patients. So that is why we had to sacrifice the iris rather than that. The only thing was here that if I could have made it 2-port limbus, and I would have stretched on the loops from both the sides, one with my assistant and one with my side. Then I might have been able to disengage it. It is very easy to untuck it when it is anteriorly fixated. When it is retrofixated, it's another problem.
Could you have taken a Caesar from behind after vitrectomy and cut the claw of the IOL?
Yeah, that's what I'm saying. So if I cut the claw is around 3.5 mm, right? So and you saw the iris becomes heavy there. And it will kind of do a swishing movement later on. And there is no vitreous to support the iris there. So it can cause a peripheral retinal tear if I leave the claws inside of the iris. So that is why we did not plan that.
Now I would like to invite Dr. Sahil Goyal, who will be presenting some interesting cases to our Dr. Sahil.
Very good morning, everyone. I'll be showing few cases, mostly on spectrum of limbal dysplasia. I'll be starting with typical ones and then taking the journey to more atypical cases. I'll be starting with this case. This particular case is a textbook. It's like a spotter. You see this keratinization on the ocular surface along with the strawberry-like lesion. You know it is OSSN. Traditionally, we used to excise it, wide margin excision, triple freeze thaw cryo. Generally, it would heal in a month. Gradually, we started using 5-fluorouracil and mitomycin, but then we shifted to non-toxic drug immunotherapy, that is interferon. Interferon alone, mostly 90% cases, it would heal, it will cure the dysplasia, but it would take long. It will take at least 3 months, and generally the immunotherapy will go up to 6 months. Multiple hospital visits and all. What I started doing was, to avoid toxicity, I would give just 1 week of 5-fluorouracil and then continue interferon. This one is again a strawberry-like lesion at the limbus with multiple feeder vessels, but there is a lot of pigment. It's an atypical variant. It's called a pigmented OSSN. This one took longer. This one took around 3 months to completely vanish, but as you can see, first visit, second visit, third visit, fourth visit, at 3 months it is completely gone. This one looks more like an invasive squamous cell carcinoma. This looks scary. Ideally, this patient was advised enucleation. Patient did not agree, was an 80-year-old gentleman, did not agree to surgery at all. No matter how much I scared him about risk of metastasis and anything, he said, I do not want my eyeball to be taken out. As a desperate measure, I gave 5-FU initially for 5 days and then continued with interferon. And as you can see, over 4 months, most of the dysplasia, most of the ocular cancer is completely gone. Moving on, this particular patient was referred to me as a perforated ulcer. When I saw first onset lamp, it looked like a staphyloma. I started wondering, what do I do with this case? I do a transplant in this entire area, preserve this area. What should be done? But when I carefully saw from an angle, I saw the anterior chamber is intact and this is the entire mass lying just on the cornea. As can be seen here, the cornea is intact. You can see temporally ask the patient to adduct and you are able to see there is no perforation, cornea is intact just on the surface. That's when I removed the pseudocornea. I removed and sent for an incisional biopsy of the superficial area and again showed moderate dysplasia, squamous cell carcinoma. As you can see here, just within 2 weeks of interferon and 5-FU, it has significantly decreased. An eyeball which could not be recognized here, in 2 weeks, you can make out there is an eyeball at least. You can make out there is a pigmented variant of OSSN. Another 2 weeks, by the end of 1 month, this eye has converted to this. Ideally, it looks like an invasive squamous cell carcinoma. It should be excised. Ideally, we should give plaque brachytherapy at the bed because it is invasive and it is most likely invading the sclera. Plaque brachytherapy is something which is rarely available, at least in North, very few people would be doing it. I do not know of any. Hyderabad, there are multiple centers doing plaque brachytherapy. They suture the plaque onto the limbus here. There is a risk of limbal stem cell deficiency. But again, this patient just does not agreeing for surgery. As a desperate attempt, I gave 5-FU and interferon, and after 1 month of interferon, you can see how significantly the mass has decreased, how we can make out the eyeball was hidden underneath all this entire what looked like a staphyloма at the first instance. Another interesting case, this particular case was referred to me. There is a lot of congestion in this area. Patient was extremely symptomatic, a lot of photophobia, a lot of watering. As you can see over this congestion, there is some mucoid discharge also. Careful examination shows that there is a whitish mass encroaching close to the pupil, going close to the pupillary area. Again, in oblique obliteration, you can say there is a spread of this thing. In ASOCT, it was subepithelial. It was again showing dysplasia. As you can see carefully on staining, it showed a lot of pseudomembranes on top of it. In sclerotic scatter, again, it is showing from the limbal mass, this is growing. Patient gave a history that 1 year back or 6 months back, there was history of surgery. As you can see the margins here. These are the margins of the conjunctival autograft that was applied then. At that time, it was treated as pterygium and pterygium surgery was done. At least 0.5 to 1% of pterygia, which we remove considering pterygium, are OSSN to begin with. 3 weeks, the OSSN almost is completely gone. The non-healing ulcer, the PD has resolved. He is completely asymptomatic, no watering, no photophobia. The interferon has to be continued for 3 more months. Unfortunately, patient could not follow up, so I gave him interferon, told him how to prepare it, and he has gone back and will continue to administer interferon. So these were 5 or 6 cases of slightly varied manifestations of ocular surface dysplasia. Thank you so much. I have around 4 or 5 more cases, but I don't think I will have the time to do that. Maybe if we get time later, I can discuss those cases also. Thank you so much. So interferon was more easily available till couple of years back by Intas Pharmaceuticals. As of now, Intas has stopped making. It is available only by Reliance by the name of Reliferon. It is 3 million international units per ml. It is available by White Pharmaceuticals from Delhi. You can just call them and they deliver courier it to you with proper cold chain preservation. You have to prepare it 1 million international unit per ml. So in a lubricant vial, you put 3 injections and you take out 1 or 2 ml of lubricants, which gives you a final concentration of 1 million international unit per ml. One vial costs almost 700, 600 to 700, and for patient, this vial, 3 vials, which cost 2,000, will last for a month. So the therapy costs almost 2,000 to 2,200 per month, and 3 to 6 months. So the total cost for the patient turns out to be 6,000 to 12,000. 4 times per day. There is no timeline for it. You have to clinically observe. You ask the patient to keep following monthly. Every month you document the decrease in size. Once you clinically cannot see any dysplasia, then you give additional coverage of 2 to 3 months to prevent recurrence. I'll share the White Pharmaceuticals phone number. I'll share with you. Yeah. Thank you so much.
Wonderful presentation, Dr. Sahil. Thank you. Now I would like to invite Dr. Saurabh Mittal. His talk is on achieving quiet eye after cataract surgery. I think one of the fascinating topic. Everybody would like to listen to Dr. Saurabh now.
At the onset, I'd like to thank DOBA Ophthalmological Society and POS for giving the opportunity to present on. This is basically a sponsored talk from Allergan.
Please wait.
So on Napafenec and the product Napafenec. So the talk is about achieving quiet eye after cataract surgery. So we do a wonderful cataract surgery. All of us, we do a wonderful cataract surgeries. But most commonly we'll end up with patients who complain of ocular discomfort, irritation, red eyes, foreign body sensation and fatigue. And this can be because of the structural, inflammatory and chemical damage that happens while surgery. What happens is there is a loss of epithelial cells and there is significant corneal edema that develops after surgery. And ocular surface and the tear film get disturbed. Even meibomian gland functioning is also get disturbed after surgery. Inflammation can occur because of disruption in the blood ocular barrier and because of entry of inflammatory cells into the aqueous, leading to this discomfort what the patient experiences. There is a release of cytokines, interferons and prostaglandins which target the ocular surface after the cataract surgery, leading to inflammation. So how to achieve a quiet eye is by achieving control on this structural changes, inflammation and the chemical changes after and before. We should plan before surgery itself. So to have a quiet eye after surgery, we should be controlling inflammation and maintain surface integrity. So this is very important because we are using multifocals and EDOF IOLs now, and we know that the demand of the patient is also on a higher side. So it's very important to have a quiet eye after surgery, to have a best outcome from our IOLs. And to achieve this, we have steroids and NSAIDs that can effectively control inflammation. So we normally use NSAIDs before surgery and after surgery, and steroids after surgery for a period of 2 to 3 weeks and maybe for 6 weeks in some regimens. So what are NSAIDs? They are basically non-steroidal analgesics. They are alternative to steroids with their minus their side effects, and they inhibit the cyclooxygenase pathway and suppresses the action of prostaglandin and other chemical mediators, preventing inflammation and provide pain relief. So various NSAIDs available are fluorouracil, ketorolac, diclofenac, bromfenac and napafenac, but they do have all these preservatives in which. Of this, best what we suggest is napafenac because it's a lipophilic prodrug which penetrates the cornea better than all other products. Time leads to ocular surface damage, destabilizes the tear film, and ultimately leads to increase in the inflammation. So what happens with the BAK is it cannot be neutralized with the mammalian cells, and it penetrates deep into the conjunctival tissues, and even with one drop instillation, it stays there for a long period. Even in low concentrations, BAK is, increases the inflammatory markers and induces prostaglandin release. Also, even in very low concentrations, it is seen to be toxic to the ocular surface cells. So even in very low concentrations, it can lead to a tear film disruption and is cytotoxic to the epithelial cells. So we should have an alternative to this BAK, and we should combine this with napafenac to have a better activity of napafenac. So napafenac, we don't require a preservative as such because it has a very high permeability and it does not need a BAK-like substance to cross the ocular surface. So purite is one preservative, which is a stabilized oxychlorocomplex, which is basically made up of chlorite and chlorate, and is bactericidal, fungicidal, and virudicidal, and it has no documented toxicity to the mammal cells. So once the purite is instilled on the ocular surface, it breaks into water and salts, and is almost same as that of tears. So napafenac suspension with purite, they produce less irritation to the ocular surface, they maintain the surface integrity, and effectively controls inflammation. To summarize, Achieving a quiet eye after surgery is important. NSAIDs help in controlling inflammation after surgery. Preservatives like purite are useful, and we should not be using BAK in most of the medicines what we use. Avoid using them. Purite is a novel alternative to BAK. It's a safe. Napafenec is having a high ocular bioavailability, so napafenec combined with purite can lead to a possible and help us achieve a quiet eye after cataract surgery. So best cure for body is to have a quiet mind, and the way to achieve a quiet mind is to have a quiet eye after surgery. Thank you. Thank you, sir.
Thanks. With that, we come to the end of the first session. I request Dr. Balwinder Damana, Director, PHC, Dr. Ranjit Singh, and Dr. Basi to honor the speakers for the first session. I will request Dr. Karandeep Rishi to accept the honor. Dr. Karan, Dr. Mitra, Dr. Mana. Dr. Mitra, Dr. Sahil Jain, please. Dr. Ranjit. Dr. Suhota, panelist for the first session. And panelists for the second session are Dr. B.S. Bhora, our president, Dr. Kuldeep Singh, senior surgeon from Hoshiarpur.
ਤੁਸੀਂ ਉਹ ਆਡੀਓ ਵਿਜ਼ੂਅਲ ਤੇ ਲਾਓਗੇ ਤਾਂ
Welcome to the second session of the monthly meeting of PUS hosted by the Doba Ophthalmology Society. At the onset, I thank Doba Ophthalmological Society to host this monthly meeting of Punjab Ophthalmological Society. So once again I congratulate and thank them. So in the next session, we have four speakers: Dr. Tami, Dr. Karamjit Singh, Dr. Saurav Mittal, and Pawan Prashar with very interesting topics. So I invite Dr. D.S. Tami for the keynote address. Which intraocular lens would ophthalmologists choose for themselves and their family? Thank you very much. Over to Dr. Tami.
Thank you, Dr. Bhara. At the onset, my thanks to the Doba Ophthalmological Society, Dr. Balwinder in special. See, when he tells you, "Do tareek book kar leo," you have not to forget it. He means it. He tells you 5 months before. So there's no chance missing it. And I have a topic which is definitely very boring. It may not make you sleep, but it will definitely alert you to some extent. which lens should I get, or which lens I should implant into my friend or a patient, which is equally important to you, because whole your living is from him, not your friend, not yourself. So choosing a lens is very difficult. You will annoy 10 sellers, 10 companies, and become a black sheep for them. Let's discuss point-wise what we ought to know. Well, I have no financial interest in in the names disclosed. But what we are missing is what the IOL is going to correct. If you remove the IOL, it is going to correct the corneal aberrations, it is going to correct the internal aberrations, and of course it is going to correct the power. One thing you can't change cornea. One thing you can do is know what are the aberrations in the cornea. And third thing is you know whether you are accurately taking the biometry or not. Well, to understand the cornea has two kinds of spherical aberrations. What is a spherical aberration is very important to understand. An imbalance of keratometric refractive power differences between the central and the peripheral cornea in the visual axis. This point of visual axis, which is 6 millimeters noted for everyone, is very important. And what is coma? An imbalance of the keratometric power vertically and horizontally with respect to center of the visual axis. Do we ever note? Let's see what happens when you don't note. Well, why don't we note? Because 90% of us have only lower order aberrations. It's called defocus and astigmatism. We are very happy. ठीक है, बिल्कुल दिखता है, बहुत बढ़िया. 6, the patient reads everything. What we miss? Higher order aberrations, the spherical, the coma, and the trefoil. Now, how to catch them and how to treat them? Very important is to understand the shape of the cornea. It can be a parabola, it can be hyperbolate, it can be oblate. Whole presbyopic, LASIK, presbyopic correction by the IOL as a refractive lens exchange depends on the shape of the cornea. How much negative or positive spherical aberration, multifocal IOL. Very good topography, very good everything. And what we have a favorite in Pentacam is look at the holiday report. And I believe most of us read only the K1, K2. And we forget there's something very important in a holiday report. What does it give you? It gives you how accurate is your keratometry. If my pointer is pointing, there is one peak which is straight. You can rely on your keratometric reading. Now next, go to the Zernike analysis. You will have higher order aberrations, coma, and spherical. Anything beyond 0.3 in the cornea is going to make you unhappy patient even after a perfect surgery. And I think we hardly note, we hardly comment. Now, what was the necessity to look at this? We looked at the aberrations here. This is the coma and this is the spherical aberration. And what you see is they are within normal limits and my patient is really going to be happy. But let's see what happens next. You see, this looks like a keratoconus. Anyone will say, what, I don't have the Bayesian embryograph with me. Why should I suspect it a keratoconus? What immediately have to look into the middle square of the holiday report. Please remember, Pentacam is very, very informative if you know how to proceed, and how to excel. Any red mark here will give you an indication that you are heading towards unavoidable high order abrasions. And the second line above, if it is not okay, if it is below 82%, that is RRN ratio, will tell you whether he had a previous surgery or not. Let's see the next. How could you get the correct K reading in this? Such a flat graft. Your biometry can default 100%. A perfect surgery, whether done on femtocataract, whether done by a perfect surgeon or by an ordinary person, will never be satisfied to the patient and guaranteed unhappy patient after a very good surgery. And that's the same case, but here I want to highlight this line which tells you RNR, gulf-stand ratio, which will indicate whether the patient had a previous surgery or not on the cornea. Now, how to get out of this? We take the help of pentagram. It decides a lot. It's a very good tool. If you can afford, if you can have, don't miss it. What it tells an IOL selection checklist. What is in it? Are the corneal higher order aberrations HOA present? If present, are they red or green or tolerable? Then what it tells you angle alpha, it tells you the higher order aberrations in total, it tells you the astigmatism, and finally it tells you go ahead with a premium IOL, go ahead with a monofocal IOL and a spheric IOL. But is this only what we are expecting? No. We want to do this. Now, this is the second case. Very irregular topography. My point to stress here is please don't do axial length. Do use your pentagram in every premium case of cataract as a routine. And what you see is higher order aberrations ranging in red, ranging beyond 1 point plus, which cannot be corrected by any intraocular lens, howsoever good it is, howsoever costly it is. Your patient is going to be highly unhappy after your surgery. Then the same case, why did he or she get higher order aberrations? This is a young lady of 46 years old, maybe 52, who came to us for cataract surgery, and we were astonished that pentagram is giving very higher order aberrations. But immediately when we went to eye trace, we found some aberrations in the cornea, maximum in the lens, and corrected were worst. So we could decide that we have to remove the lens with an IOL which would correct these corneal aberrations to some extent and give the patient a good vision. Mind you, all these people, NRIs who come to you for a clear lens extraction or an early cataract, spend a lot of money, they compare it with their expenditure in their country and then ask you a question. I had a patient from London, he wanted an extended depth of focus lens. He kept talking to me, listen, let me first tell you the cost. I told him the cost and I told him, don't spend in India, this lens is given free to you in London. Can I really? Yes, go and get operated in London, get off my head. Because that lens is available in NS services. So be sure what you are trying to implant is going to help the patient, and really what he's suffering or spending from his pocket is in his mind, not you as a good surgeon, not as a good lens. Surgery done. Because RK does not alter the gulf-stand ratio. It doesn't alter the anterior or posterior surface. But what it alters is this. Who will choose a keratometric reading in this case? We cannot. Now what I do is, when a patient of such category, such a patient comes to me, I put the IOL master in front of him, I put the pentacam in front of him, tell him, how can I be accurate? Because believe me, I should share because you are my all colleagues. Recently, I had a police case against me that I have created 0.5 myopia after cataract surgery in one eye and emmetropia in the other eye. Because the patient didn't want to wear glasses. He did not understand the principles of surgery, protocol of monovision, protocol of extended depth, but only my police officer could understand. I didn't want to argue that how did you reach the police station, but I could impress the officer coming to me. This man doesn't understand. He has only one thing, मैं पढ़ना नहीं, मैं देखना नहीं, मैं तो दिखना चाहिए, ऐनक तो बगैर. Then I put forward him the IEL master. IEL master always gives you the IEL master reading in fractions. Nowhere in the world there is a lens which is powered as a 21.03. It will be 20.5 or 21. How can you keep thinking that you're doing best surgery when one fool of like this enters to you? And not this, he was a fool. But one of my colleagues argued with me why this lady had 0.5 in the left eye. Be sure that she is emmetrope in the. My God, listen, you're getting a lady to me who is already hypermetropic by 9 diopters. So be sure that you have some documentations to prove and you have in your mind that where I am committing a fault. And you are not committing a fault. You are the best surgeon. You are committing the fault which technology is giving you or the sellers have put into your mind, this is the best lens, this is correct, this is this correct. He has made fool of us. Again, we will look at the higher order aberrations, especially the spherical aberrations in this, if you happen to read the Zircon analysis. Why I'm taking this topic was about 20 years back, maybe less, myself and Dr. Thind were together in Paris. I presented a paper on correcting presbyopia with a normal excimer laser, increasing the spherical higher order aberrations. But then my mentor, my friend, Dr. Theo Seller told me, that's Dr. Dhami, forget about cornea, this will come onto the lens. That's how these EDOF lenses came up after so many years, and we have done them. But, sorry, we are forgetting the cornea, which is very important, and the only refractive structure you are not going to touch, not going to change. Now, what is the protocol with us? We do eye trace. We see the angle kappa, high angle kappa, go for a monofocal. This is the ideal lens, no complaints, nothing. The patient has not paid you more than what required and you are happy. But if the angle kappa is high, forget about your trifocals, whether it is from A company or B company or the Indian company. Look at the Chang analysis. What are the higher order aberrations? They will tell you what they are. Accordingly, change, check, and implant EDOF. Low corneal aberrations and toricity present. Choose a toric lens which will give patient a perfect surgery. Toric lens are boon to us today. Multifocals are a nuisance for us whenever you implant. Well, these are some normal ranges. No cutoff values, affected by age, ocular surface, dry eye accommodation, affected by population, and affected by devices, affected by previous surgeries. And normal should be between ranges of minus 0.35, suspected anything above that, abnormal above 0.5. Be sure that if you have corneal aberrations are above 0.5, trifocals are out of picture. Now, how to choose a lens? If it's a normal value, you can go for two things. Either the patient wants depth of focus or patient wants image quality. Dr. Thind-like person wants image quality, he always drives fast. Why would you after him a depth of focus lens? It is going to decrease contrast, it is going to decrease the total vision of obtained. ਸਾਡੇ ਵਰਗਾ ਬੰਦਾ ਕੁਰਸੀ ਤੇ ਬੰਦਾ ਸਾਨੂੰ ਡੈਪਥ ਆਫ ਫੋਕਸ ਚਾਹੀਦਾ ਥੋੜਾ ਜਿਹਾ ਪੜਿਆ ਤੇ EDOF ਪਾਤਾ. Lamp which has zero aberrations, which will solve many problems coming on to the next talks. Then what? I have to believe the industry, which lens I have to put, what measurement I have to take. I have told you pentagam, I have to interlace, but you have only a biometer. That's not the end. Well, this chart is put in our OPD. The cataract is diagnosed, optical biometry is done, the corneal tomography is done, that means pentagam is done, and looked at the higher order aberrations, corneal spherical aberrations, depth of focus from the cornea, and of course, without fundus dilatation, clarification from the retinal surgeon, not the surgeon like me who is doing cataract surgery. We don't proceed to cataract surgery. Note the angle kapha, note the scotopic pupil, and go ahead. But remember, your corneal cylinder should be matching with the optical cylinder nearly, and qualitative assessment of the surface. I don't need to mention, Dr. Saurav has talked a lot and very nicely, and posterior corneal astigmatism has to be taken into consideration. This is the chart given to our counselor, and then she tells me, sir, we can go with this because you are already loaded with patients who only drawback of private practice is you don't get time to think. Now, yes, like the case I told you, patient selection is very important. What does he want? He has come for only cataract or something else. Accurate biometry and perfect eye centering in the back. Everyone does not have a femtocataract, which is not required. You have to center your IOL onto the Purkinje images seen by you in the microscope. Patient knowledge. Everyone is knowledgeable more than me. I have a common word in my practice. I am the only one who doesn't know medical practice. You know better than me. Everyone knows better than you. Be sure the person sitting next to you knows much more than you, because you don't know what you want. High expectations requires extensive counseling. Forget about them. Tell them you're going to have a cross, you not have a good vision, you will come complaining to me, chup karke monofocal ya toric pawalo. Patient who has a little knowledge, you can tell him. You can ask him. If he is a child whose axial length is going to increase, how much power you going to leave, he will understand. After even 15 years, 20 years, he'll come to you, sir, you told me this, now my myopia has increased, kindly correct it. They are the best patients. Patient who don't have any knowledge, housewives, workers, ladies, chup karke panoptics pado, they're very happy. Pre-operative counseling, I have talked, profession is very important, note, driving. बड़े बंदे ड्राइवर भी नहीं कहते मैंने ग्लेयर पहनती है. I am surprised. But they are fond of not wearing glasses. Demanding professions. Now, I will ask one question. There is a patient with me who is a shooter and of national level. I cannot commit a mistake. He wants his left eye seeing the जिथों अपन निशाना माप दें and his rifle, and with the right eye he wants to see the target. I postponed him for 3 months. Listen, I can't decide. Then finally I decided that you're going to have a monofocal in one and a EDOF in one. See, these patients, the whole profession is demanding, sir, मैं national level the champion है, मेरी जे आँख खराब होगी तो मैं तो shooting नहीं होनी. So you have to be careful. It's not the price, it is not the company which matters. Remember, it is the patient who matters. And that's what I have talked about. Address to the patient. Don't think what you want to convey. What he wants to know is very important. Definitely. मैं वो बंदे नू क्या तेनू मोनोविजन बनाई आ तेनू यार प्लेट च बैठे दाल नहीं दिखनी केड़ी आ क्योंकि I have a friend. Before eating his lunch dinner, he wears his presbyopia glasses. He is a prominent eye surgeon. He didn't agree. कहना सर मैं की देखना मैं तो चुप करके खा लेना तुसी मेरी number 0 करो. So please ask probing questions. But toricity is very important. People do not tolerate even a 0.5 cylinder. You have to manage it. Again, Dr. Saurav's talk, I won't talk here. Tear film and dry eye are the most common factors which are going to trouble you. रड़क पैंदी है, पानी आंदा है, ये आंदा है, मुकदा ही understand what they are. Remember, patients will not tell you anything. Patient will not tell you any coexisting morbidity. He will not tell you he's a cardiac patient. He will have trouble on the operation table. And only thing is, मैं तो पैसे देते सी. Be very, very careful. Of course, IL power calculation is challenging. I told you RK and in post-refractive have to be taken into very careful conditions. Yes, morphology of a cataract. Now, of course, we have a femtocataract. We can solve any problem. Any expert can do. I have seen Dr. Poras doing multifocals in a pre-existing tear, but then everyone cannot. You should know what you can do and what. I changed the lens on the table and patient fought with me, sir, मैं तो ये पवाना ही नहीं सी. मैं कह के गया सी ये पवाना तुसी J&J दा फिर पाता. That was the monofocal. So, all trifocals cause halos. Please limit yourself to the cost and the company and the medical representative visiting you, trying to convince you. Patients, mind you, require crisp vision. He will not stop. Any nightmares of vision, bus driver, truckers, avoid them, explain them. But now we have a choice of lens. I've already talked about this. What lenses then you have? You have refractive, you have diffractive. We have cut down both. Diffractives are multifocals, the refractives were bifocals. What we can choose from is what are wavefront optimized or what are abrasion related lenses. What do you want to give to the patient? You yourself would like to have an excellent focus. This is monofocal. You will like to have a blur but want to read. Cannot read, but an EDOF will give you extended depth of vision. Remember now about the positive spherical abrasions in the cornea. They focus two foci in the retina, one in front, one on the retina, that is EDOF. And that range gives you what you want to do this. So all ages EDOF, quality of vision good but less than monofocal. Distance and intermediate satisfactory. Active lifestyle, frequent drivers can have. People who are sitting on laptop love it. Poor readers like it. Less restrictions along the inclusion criteria, more forgiving. Now, let's talk about three lenses, 3 minutes. An Innovate lens, this is a great lens which I told you long back. I was told in Paris. This has come now. This is a pure C lens which has higher order operations more than required, and it is giving very good results. Very, very. I put more than 20 very happy patients. It is innovative, refractive design, linear power transition, and customizable features. The company doesn't disclose as yet what it is, what are they doing, but I want to disclose it has abrasions on the anterior surface, it has abrasions on the posterior surface. They add and give you a depth of focus approximately about 1.75 to 2 diopters, which is enough. Now this is the lens, this is how it looks on the microscope, and if you can see it has rings, but these are not rings, these are variations in these spherical abrasions. And it gives minimum halos and glare to a great satisfaction. Patients are very happy. This is the second, called as pure refractive optics from Hoshiarpur. The only greatness why I have put this lens here is for the zero spherical abrasions in the center. You can use it at many occasions where you want to be safe. But it works on the same principle, it's a good lens. And this is one coming from an Indian company, it is very good. I have used it, but no. Now, this slide. Whenever this man, earlier lens who brought to me this lens, I told him, yaar, kyun dikhai? Yaane pehle samjha de hai ki. What you tell me, what are the higher operations in this and how much I will correct? कहना sir, ये केड़ा कोई देखदा? तुसी एक बंदे हो. So I am the only black sheep among the all white ones. कहना सर तुसी ज़्यादा पुछदे हो, तुहाडे नाल गल ही नहीं करदे, असीं जाने. मैं कहा जाओ. So be sure you are not being traded, tackled, and confused by the trade. They are paid for it. I will not forget and hesitate to mention here. All raised portion of 1 millimeter will shape the vision it is going to give you. It is going to give you an extended depth. This is VVT. VVT, this only is not the VVT, it is from an Indian companies also, it is made from other companies also. This is a good lens, but it is creating a shape. It is not taking care into the total abrasions on the cornea. So this can also give halos to some extent, whereas lenses which are purely on aberration profile extended all along like a refractive changes were the best to be used. Like a refractive changes were the best to be used. Well, now this is very important slide. No diffractive rings, only smoothly elevated plateau. This is a good tolerable lens called as VVT. But these lenses have multiple diffractive rings, are not tolerated as much as you like. They say IT Lara doesn't give this. I have heard so many times that IT Lara is a very good lens. But mind you, your patient is very important. He's going to complain you whenever you like. And this is again important. Now comes the role of femtocataract. Any defocus, any tilt, any decentration. Now this is where you need perfect rexis by femtocataract, femtosecond laser. It may not be helpful in removing the lens, but it is definitely helpful to center the lens perfectly, otherwise you can have problems. Someone asked me, why don't you have femto laser till now? You should have it. I said I created all complications during IA, irrigation and aspiration. Why should I buy femtocataract? My complications occur when I polish the capsule. He didn't have an answer, so I never had bought femtocataract. Take-home message is, there are many, many great solutions, paid in colors, paid by very intelligent people coming to you for presbyopic correction. You can convert all monofocals into EDOF. Please note the higher order aberrations. Know what the lens is having the aberrations. Monovision can be given. Be careful about the patient I described. Very high satisfaction to the patient is the choice lens which I would like to have in my eye, but with the proper counseling that I will need glasses to read. Now this line kindly underline. I told my counselor, tell them, give them free glasses of 1.2 or 1.5. Sir ji फिर पवाऊगा कौन? वो तो कहता मैं ऐनक तो लानी नहीं. Be sure if you tell them that you are going to wear glasses of 1.2 for 1, he will never go for multifocal. Oh, ऐनक तो फिर लगी. So they don't understand. You will have to choose your patient. I didn't understand what was the answer. Now we have in a consent that you will need glasses, whatever lens you need. Never talk about not wearing glasses in your clinic. We are cataract surgeons. We are not refractive surgeons. Even refractive surgery, I tell this cannot be zero. No excimer, no smile, no silk will get you 0, 0 refraction. It is going to leave behind some aberrations, which we talked as higher order aberrations in the pupillary area to give you comfort. And how big is your pupillary area? That you can measure on the pentagram, you can measure on this one. So mind you, this was the last story I was taught in 5th class, Cinderella. She had only one shoe to be fitted. There was one girl, and that was one prince who's going to marry that girl. Right lens, right patient, right expectation. Every lens is not for everyone. Thank you very much. And last thing, it is the painter who's important, not the canvas. I have this photograph, very old. I visited this, is a great surgeon, great thinker, probably Dr. Mascott I'm talking about. One of the webinars on ESCRS, we were speaking the same topic, what lens to choose for a surgeon. And he quietly said in the end, I am the only unlucky one who 40 years back, he was then 70, 40 years back, I got operated with extracapsular cataract extraction and a 3-piece silicone lens. But he's still a perfect, most paid, highly paid surgeon in California. So, mind you, lens doesn't matter. It is the you who matters, who paints the canvas, and the painter is you. Thank you.
Thank you very much, Dr. Tami, for such a beautiful subject. To start with, said you say very boring. I think is the most interesting
Thank you.
topic. I think it will invite so many.
You will not decide what you need. I will tell you what you need. You decide what to pay. So that's how I move.
Must be very difficult for you.
I speak only 3 lines. Rest is done in the now in my hospital. Every girl or a boy is told that chart. He's taught what are the red flags in a pentachem, what are the red flags in the axial length measurement, and what are the red flags in eye trace. So they tell me only the summary. Otherwise you are lost. You have not much of time. We are not people who will see 5 patients. We have to see more than a series of 450 patients. And last line I say is my vitreoretinal surgeon is going to clear whether you're going to have a multifocal or not. If he or she clears, only then the patient is subject to what we call as panoptics. Otherwise, no.
You still do micro monovision?
Always. Always. I tell them this is God-gifted vision.
It's very good thing.
My friend who is the leading eye surgeon has minus 1.5 in his one eye and plano in the other. Oh, enni tej kadi chalanda pucho na. Enna acha surgeon hai. Why don't you like this? But they don't like. Anak nahi lani. Bas ek ek word unhone man ch pe aave anak la li. ਉਹਨੇ ਤਾਂ ਕੈਂਪ ਚ ਕਰਾਇਆ ਸੀ ਉਹਦੇ ਤਾਂ ਐਨਕ ਲੱਗੀ ਨਹੀਂ. That's the point. So I tell you, even PMMA, your own used PMA must be better than all these lenses today.
And most of us have monovision natural lenses.
If you have it, you are a very good surgeon.
We have to convince them also.
That's what I will like to have in my eye. I'm already myopic, and I love myopia.
Thank you very much.
Thank you.
I think the take-home message from the talk is that every eye surgeon should tell the patient that after surgery ਐਨਕ ਵੀ ਲੱਗ ਸਕਦੀ ਹੈ.
ਐਨਕ ਉਤਾਰਨੀ ਹੋਣੀ
ਔਰ ਉਹ ਐਨਕ ਵੀ ਲੱਗ ਸਕਦੀ ਨੂੰ ਜੇ ਮੈਸੇਜ ਲੈ ਕੇ ਜਾਏਗਾ ਪੇਸ਼ੈਂਟ ਤੇ ਜੇ ਐਨਕ ਲੱਗ ਗਈ ਤੇ ਉਹ ਤੁਹਾਡਾ ਸਿਰ ਨਹੀਂ ਖਾਏਗਾ.
ਯੈਸ.
ਤੋ ਇਸ ਕਰਕੇ ਜਿਹੜਾ ਮਰਜ਼ੀ ਲੈਂਸ ਚਾਹੇ ਪ੍ਰੀਮੀਅਮ ਪਾ ਲਓ ਚਾਹੇ ਜਿਹੜਾ ਮਰਜ਼ੀ ਲੈਂਸ ਤੁਸੀਂ ਪਲਾਨ ਕਰ ਲਓ. ਪੇਸ਼ੈਂਟ ਨੂੰ ਇਹ ਲਾਈਨ ਘੱਟੋ ਘੱਟ ਮੈਂ ਜ਼ਰੂਰ ਕਹਿਣਾ ਕਿ ਸਭ ਕੁਝ ਬੈਸਟ ਕਰਨ ਤੋਂ ਬਾਅਦ ਵੀ ਐਨਕ ਲੱਗ ਸਕਦੀ ਹੈ. ਤੋ ਉਹ ਮੈਸੇਜ ਲੈ ਕੇ ਜਾਂਦਾ ਉਹਦੇ ਨਾਲ ਦਿਆਂ ਨੂੰ ਨਾਲ ਜ਼ਰੂਰ ਬਿਠਾ ਲਓ.
ਨਾ ਜੀ ਉਹ
ਕਿਉਂਕਿ ਜੇ ਨਾਲ ਦੇ ਨਹੀਂ ਬੈਠਣਗੇ ਉਹਨਾਂ ਨੇ ਇਹ ਗੱਲ ਸੁਣੀ ਨਹੀਂ ਹੁੰਦੀ ਤੇ ਉਹ ਬਾਅਦ 'ਚ ਫਿਰ ਜਿਹੜਾ ਉਹ ਸਾਰਾ ਜੀ ਇੰਨੇ ਪੈਸੇ ਖਰਚੇ ਫਿਰ ਵੀ ਐਨਕ ਲੱਗ ਗਈ. ਤੋ ਇਹ ਜਿਹੜਾ ਇੱਕ ਮੈਸੇਜ ਹੈਗਾ ਕਿ ਯੂ ਮੇ ਬੀ ਗਿਵਿੰਗ the best lens, but it should be best for the patient and needs of the patient should be considered and this line should be added.
And to add this, ਅਸੀਂ ਉਹਦੀ handwriting ਜੋ ਤੋਂ ਲਿਖਾਨੇ ਆ.
Very good.
ਵੀ ਐਨਕ ਲੱਗੇਗੀ. We are not removing your glasses.
Another, sometimes you feel this patient is going to trouble you. Not only your cataract patients, it could be any patient, glaucoma. You must take a video consent.
Oh yeah, this is very difficult. After this,
just make the attendants also stand behind, and then you start talking and take a video consent.
No, this is we planned after this case. ਜਿਹੜੇ ਪੁਲਿਸ ਵੀ ਲਿਆਂਦੀ ਪਰ ਉਹ ਮੈਨੂੰ ਸਮਝ ਨਹੀਂ ਆਉਂਦੀ ਪੁਲਿਸ ਲੈ ਕੇ ਕਿਵੇਂ ਆਇਆ. ਆਈ ਡੋਂਟ ਮਾਈਂਡ ਵੀ ਆ ਗਿਆ ਕੋਈ ਜਦ ਕੋਈ ਫਾਲਟ ਹੀ ਨਹੀਂ ਆਉਂਦੀ ਪੁਲਿਸ ਆ ਗਈ ਤਾਂ ਕਿਹੜੀ ਗੱਲ ਹੈ. ਬਟ ਯੂ ਸ਼ੁੱਡ ਬੀ ਅਲਰਟ, discriminate, and understand that you are not working for a company.
And tell your patient, don't do like this. Don't do the see both eyes. You're born with the 2 eyes.
ਉਹ ਕਹਿੰਦਾ ਜੀ ਮੈਂ ਡਰਾਈਵਰ ਹਾਂ ਮੈਂ ਡੈਸ਼ਬੋਰਡ ਦੇਖਣਾ ਹੀ ਨਹੀਂ ਮੈਂ ਸਪੀਡ ਦੇਖਣੀ ਨਹੀਂ ਮੈਂ ਤਾਂ ਸਾਹਮਣੇ ਦੇਖਣਾ.
ਨਹੀਂ they start comparing 2 eyes with one maybe 0.25 monovision 0.5 monovision.
this is the only talking we do. ਹੁਣੇ ਮੈਂ ਡਾਕਟਰ ਸਿੰਘ ਨਾਲ ਬੈਠਾ ਕਰਦਾ ਸੀ, ਮੈਂ ਪੜ੍ਹਾਈ ਤਾਂ ਪਰੇ ਰਹਿ ਗਈ, ਆ ਗੱਲਾਂ ਰਹਿ ਗਈਆਂ. Okay, thank you very much. Thank you very much, Dr. Balwinder. Thank you very much, Dwaba sir.
So making them aware and I will say more aware about when to send the patient for ROP and so and now to the medical legal complications going ਹੁੰਦੀਆਂ ਉਹਨਾਂ ਤੋਂ ਥੋੜਾ aware ਰਹਿਣ ਵਾਸਤੇ. So there are some I thank dietitian friends for joining us.
Respected chairpersons. So first of all, I am thankful to the Waba Ophthalmological Society for inviting me in this wonderful CME. Thanks Dr. Balwinder and his team. So my talk is very simple. Basically, what are the challenges that we are facing in our day-to-day practice? It is not only by the retinologists, it is not only by the ROP persons, the surgeons who are doing ROP, it is faced by the pediatricians, gynecologists, and general physicians, and also general ophthalmologists. So we should know what are the challenges and how to overcome those challenges, which is very important. So first challenge is how to run those slides. Close. Close कर दो फिर चलेगा. नहीं नहीं मैं ले आना हूँ. कोई नहीं इन्हें यूज कर लो. So what are the challenges in screening and management of ROP? So as we all know that many of the causes of childhood blindness are avoidable, being either preventable or treatable. ROP remains one of the most preventable cause of childhood blindness worldwide these days. And you should be surprised that India accounts for nearly 10% of worldwide estimate of blindness and visual impairment. So there is a huge load of ROP in India and ROP related complications. And these days, India is basically facing third epidemic of ROP. So ROP screening and management in India face significant challenges, including shortage of screening workforce, which is a most important factor in the challenges that we are facing these days. and also lack of uniformity in ROP screening across the nation. So there are so many guidelines. There are guidelines by Indian Academy of Pediatrics. There are guidelines by the ICROP group. There are guidelines by the different institutions. So there is not a uniformity in guidelines of the ROP, and also there are lack of resources because we need some costly equipments to document these ROP related complications and ROP screening. And also the most important factor is there is a limited collaboration between pediatricians and ophthalmologists, and also suboptimal coordination between the public and private sector. So the child is admitted in a neonatal intensive care unit or when the child is with a pediatrician, the screening is possible over there. We screen the child in the NICU or with the pediatricians, but after that there is a poor compliance from the parents. We advise the parents that your child may need repeated follow-ups, but because of so many factors that child remains with the parents only without the follow-ups. So ROP screening may require multiple screenings. Even if in the first screening you told the parents that your child is all right but needs repeated screenings. So when you told the parents that your child is all right, then the parents thought that there is no disease. But after sometimes few findings are missed in zone 2 anterior or even in zone 3. So those findings after sometimes they develop to vision threatening ROP. So it is very important that ROP's screening requires. So it is very important that multiple screenings are required and parents are educated about the importance of multiple screening to the premature babies, and lack of knowledge about the disease among medical persons even. So sometimes there is a little knowledge of ROP to the medical persons, and importance of frequent follow-up should also be told to the pediatricians, the physicians, the gynecologists, and the paramedical staff also. So lack of proper counseling to the parents is very important. So how to do counseling in about ROP to the parents? So a proper counseling and reminder by the neonatologist, because neonatologist is the first encounter to the premature baby. So will be a better impact as the parents are confident in them. So pediatricians or neonatologists should counsel the parents about the disease and should tell the parents about the repeated follow-ups and should tell the parents about the complications that can arise from the disease if the child is not frequently followed. ROP nurse, so the nursing staff which is deputed in the neonatology units or with pediatricians, they play a major role as they have a more frequent interaction with the babies and the parents, and sometimes the pediatricians are very busy, neonatologists are very busy in treating the other babies. Then it is the duty of the nurse which is posted in the ward that she frequently highlighted the complications that can occur in the premature babies to the parents. Parents should be counseled and reassured by the ophthalmologist that screening and laser treatment will not cause any harm to the children. So in rural areas where the incidence of prematurity is very high, the ASHA workers may be educated about the ROP screening. I think in Punjab they have incorporated in their primary health program also, and need for the follow-up so as to counsel the parents in the daily home visit and play a important role in improving compliance and follow-ups. So it is seen that there is a low coverage of ROP screening and treatment services. So it has been reported that majority of the babies present with stage 5 disease due to lack of screening. So low screening rates are basically due to lack of awareness among neonatologists, pediatricians, and non-availability of trained surgeons, trained ophthalmologists in ROP screening. So this is the problem, especially in our border belts, where few ophthalmologists are doing ROP screening. And even after identifying a baby requiring laser photocoagulation, treatment is delayed, so leading to stage 5 ROP, either because of lack of treatment, the institutions which are doing treatment, or because of the negligence on the part of the parents, and inadequate quality of neonatal care. The scale up of neonatal care in the baby is born at 34 weeks and the birth weight is 2 kg. The neonatologist or pediatrician tells the parents that there is no need of screening because your baby's birth weight is normal, gestation age is normal. But after some times, the child comes to ophthalmologist with the parents noticed that there is a white reflex inside the eye, and that is stage 5 ROP. So these mature and heavier babies are sometimes missed for screenings. And nowadays, Ministry of Health, Government of India has incorporated ROP screening in a national program for control of blindness and visual impairment. They says that all babies, irrespective of gestational age, irrespective of their birth weight, should be screened for ROP. But the Indian Academy of Pediatrics says that the babies born before 32 weeks of gestation and less than 2 kg of weight should be screened. So there is a discrepancy in guidelines of the Indian Academy of Pediatrics and Ministry of Health, Government of India. But as a thumb rule, all babies should be screened for ROP to see whether the retina of the baby is normal or there is some doubt by the ophthalmologist. And delay in treatment is the most important challenge. Sometimes babies are brought only after noticing a white reflex in the eye at about 6 months of age or so. So that delay is due to lack of awareness about the rapid progression of disease. So we call it a 10-week disease. We have to screen the babies within 10 weeks. We have to treat the baby within 10 weeks, and we have to tell the parents within the 10 weeks now your baby is disease free. So due to lack of awareness about the rapid progression of the disease within 10 weeks, the parents think that they can delay the laser and are apprehensions. There are so many apprehensions about laser treatment to the parents, thinking that it is harmful and painful to the babies. So you must counsel the parents that this laser treatment is not harmful and it is not painful. We are doing lasers under topical drops. There is no need to anesthetize the baby. There is no need to give general anesthesia or local anesthesia to the baby. And there are so many challenges in the tertiary care also. Facility at tertiary care are also lacking in tackling vision threatening complications. At so many tertiary care centers, there are not trained ophthalmologists who are trained in ROP laser or in ROP surgeries. Even in medical colleges, in medical colleges of India, very few ophthalmologists are trained in laser treatment and tackle advanced ROP diseases. And surgery, it needs lot of expertise, which is not sometime present in all the medical colleges. And also there is a high financial investment in treating the complications related to ROP, in documentation as well as in managing the complications. And sometimes the time constraints. So busy ophthalmologists who are doing anterior segment only, they sometimes ignore the baby or they refer the baby to some other centers. And parents, after they start delaying the baby to be screened by the trained ophthalmologists. And another part is rehabilitation services. Even after laser treatment, after giving anti-VEGF injections, the rehabilitation of the baby, it is very important, and these services are present at few places only. In children treated for ROP, the reason for visual impairment are the basically structure abnormalities. That can be either by the retinal detachment, macular dragging, optic atrophy, refractive errors, which are very common after laser treatment. The babies which are treated in our institution few years back, they are coming to us with high myopia and strabismus, of course. You have to treat those ROP related complications even after treatment, and also correction of amblyopia, which is very important. Cataract formation are common in after giving anti-VEGF injections, glaucoma, and sometimes the patients come with cortical visual impairment. So parent education for screening, not only for treatment with the laser or anti-VEGF agents, even for screening the informed consent is also required. And also inappropriate treatment decisions, whether the disease requires anti-VEGF agents only or disease require laser treatment. And poor documentations. So you should document the disease at every visit, and you should keep the record, the duplicate copy of that documentation with you to prevent further medico-legal complications. So poor documentation is another factor for medico-legal issues. And also communication failure. Sometimes we are in a hurry, so we are unable to explain the disease to the parents. So you should communicate in clear language to the parents or to the attendants of the baby that this is the disease and I am going to do this treatment, and your child need repeated follow-ups. You should mention the follow-ups on your documentation at each visit. If the baby is not coming on that day, so you either telephonically inform the parents and document that the parents are informed telephonically for follow-up, and the child or the baby or the parents not reported for follow-up. And standard of care variation, of course this is a discrepancy. So next month there is a joint meeting of Indian Academy of Pediatrics with the National Program for Control of Blindness in New Delhi. I think the variation in the screening protocols that can be discussed in that also. Then how to avoid medico-legal risk. So adhering to the established guideline, it is very important. Thorough patient evaluation is very important, and open communication with the parents. So although it is time consuming, but you should communicate the parents about the disease and prompt referral to the specialist. If you find that you have not sufficient infrastructure to treat that disease, refer to some higher center, and that must be mentioned in your documentation. And maintain detailed documentation, of course, is very important, and continuing education to your colleagues, to your fellows, that is also very important. So these are the few, for the sake of time I am omitting this. These are the, so for our pediatricians and physicians who are present here, so management of ROP, in brief I am telling. So screening of at-risk babies, then this should be the protocol for management. Then diagnose the decision whether to treat or not to treat, treatment of the disease itself or its complications, whether to observe laser or do surgery, then correction of the systemic factors by the pediatricians, and treatment of ROP related complications. After that, post-treatment follow-up and rehabilitations. So it is very important that ROP, it is the disease which is not present at birth. So which baby to screen, it is very important. Babies less than 2000 grams and less than 32 weeks of gestation according to Indian Academy of Pediatrics criteria. But as per national program, all babies, irrespective of their gestational age, irrespective of their birth weight, should be screened. All preterm babies whose gestational age is not known should be screened. The onus of getting baby to the eye specialist is with the physician, with the pediatrician, with the gynecologist, or with the medical persons attending the premature baby. When to screen? So sometimes the pediatricians or neonatologists, they refer the baby immediately after birth. So it is very important that this is not the disease which is present at time of birth. So it develops 4 weeks after birth. So the first screening should be done at 28th day or 30th day after birth. This is very important. Or day 20 in very premature babies who are born less than 30th week of gestations. So there is no need to refer the baby before 28th day of birth. But you should tell the parents that at 28th day or at 30th day, the screening by the ophthalmologist should be done to see whether the child has ROP related disease or not. And you should also tell that if the baby has treatment, then there is treatment option in the form of laser treatment, which is 100% effective. It is available, and laser is very simple to do. It indirect ophthalmoscopy. Another option, which is a very good option available these days, is anti-VEGF agents. So anti-VEGF agents, bevacizumab, ranibizumab, or aflibercept can be, they are basically used to treat the ROP, which is basically present in zone 1 or the posterior ROP. So, but you should remember this thing that although it is established treatment these days, and reactivations are common after anti-VEGF agents, which should be taken care of. And surgery, it is the simple lens sparing vitrectomy, or these days so many advances are there in surgical treatment are available. So to conclude my talk, so India needs to gear up to face the challenges of third epidemic and prevent ROP related blindness, which is need of the hour. ROP remains one of the preventable cause of childhood blindness. So emphasis should be laid on improving the quality of neonatal care and expansion of screening and treatment programs. So multidisciplinary team approach is essential. So there should be a coordination between gynecologists, pediatricians, physicians, and ophthalmologists. So improving awareness among community-based health workers and parents, along with trained medical professions like pediatricians, ophthalmologists, nurses, can help in effective and prompt care in India. Medico-legal issues which are emerging these days. So many advocates are moving these days in tertiary care institutions searching for the ROP babies. So they should always be kept in mind while treating a baby with ROP. So thank you very much for your patience hearing.
Thank you, Dr. Karamjeet, for sensitizing the pediatricians present here and the ophthalmologist regarding the need of screening for the new upcoming medical entity, that is ROP. So it has many medico-legal aspects. So thank you very much for elaborating. I have one question, that how do you examine the fundus of a 1-month-old child without anesthesia?
Sir, it is very easy to examine. So just as shown in the picture, so we wrap the baby in sterile sheet, and after putting pediatric eye speculum under topical drops only, topical proparacaine eye drops, and with the indirect ophthalmos, such child automatically focuses in the light. There is no need to even move the eyes. So first we see the central retina when the child is focusing in the bright light of the indirect ophthalmoscope, and after that with simple manipulator, that is our wire vectors, which we use routinely for our cataract surgery. So we move the eye temporally, nasally, superior, inferior, and we can examine the retina in all quadrants. It is very easy it is very easy to screen the baby under topical drops. So you need only pedetic wire speculum, then this wire vectors and proparacan eye drops along with indirect ophthalmoscope and 28 diopter lens. So you can miss the findings with the 20 diopter indirect lens, but with 28 diopter or 30 diopter indirect lens, you can easily examine the peripheral retina, because this disease is mostly present in the peripheral retina.
So what about scleral depressor use
No. So then you can confuse as a ridge or a line with the, never depress the baby's eye. So you just manipulate the baby's eye with the manipulator, never depress. Otherwise you can confuse. So pediatricians or general physicians, they should be trained. They should be trained that they should refer the premature baby, or they should screen all the babies. So this is now incorporated in our national program for control of blindness and visual impairment, that you should screen all the babies. We are screening all the babies born in our hospital, so that not even a single, because it is seen that so many other factors are there, so many other maternal and so many other factors in the baby are there, that we are even receiving the heavier babies of 2.5 kg or 2.6 kg with ROP. So every baby should be screened these days.
I'll also like to add one thing. As Dr. Tanya said, slowly and steadily we will have to involve even the obstetricians and gynecologists also. So it has to become, ROP is becoming so rampant with the high-risk pregnancies and the preterm babies being saved. The high-risk pregnancy, when the mother has a high-risk pregnancy, that should be the time when you should actually start sensitizing the mother and parents about need for ROP screening and maybe ROP treatment. The other thing which I wanted to add to what Sir was telling about the examination with the 28D lens, ROP is a disease where you have to define them into stages, zone 1, zone 2 and 3.
Yes.
Usually zone 3 disease doesn't actually need any treatment. So if you use a 28D lens and put the disc in the center of your view, so one view which you see in ROP, it is not that tough. Thank you.
Yes.
That is a good, I think that is a good suggestion, that every PG should be trained to
Yes.
look at the fundus of a newborn in the pediatric or in the gynae ward. That
Yes.
should be part of the curriculum.
Yes,
You
sir.
being in a medical college, it should be started from you. So I think the
Sir,
take-home-
even in US, I visited one institute in California. There, the pediatricians are also trained in screening of the fundus of premature babies.
That is possible, but in our country, even if the ophthalmologist they are trained to do, that will be enough, because
Yes,
the
yes, sir.
pediatrician will not do that. So the take-home message for the gynecologist and the pediatrician is that any child who is put on oxygen, pressure oxygen, who is put on oxygen, should be told that, look, we have saved the life of your child. The vision can only be saved by the ophthalmologist, and you should go.
Are using monitored oxygen. So the role of oxygen in causing the ROP related complication is very less. There are so many other factors these days. So oxygen, because pediatricians are using monitored oxygen, they are not using 100% oxygen all the time. So oxygen, although judicious use of oxygen should be there, but monitored oxygen should be used to save the life of the baby. After all, life is also important. Ji sir.
Proper documentation. How long the document should be preserved?
Sir, sir, actually, if the baby is normal at 6 months of age, then there are almost negligible chances to develop ROP after that. So at least, so we advocate that at least for 1 year, that document should. So that is also a good suggestion by that my colleague. Yes. If you have treated the patient, then that record should be preserved at least for 15 years, sir.
And they are unfit, they will sue you.
Is also equally good as compared to the written documents, because nowadays most of the institutes have the EMR.
No, EMR definitely it is good, but as far as the medical legal things are concerned, paper consent should be there with you.
Yes.
For a record.
Signed by the parent.
Yes. Yes.
Signed by the parent.
Yes. Documentation means a proper documentation that like anybody who is not mature, it should be signed by the attendant or the parents or maybe anybody who is responsible for that. It should be signed by them. Screening documents, treatment documents, and everything, like whatsoever you've done.
Hello, Dr.
So thank you very much, sir.
One question.
Yes, sir. Yes.
Now these intravitreal injections have come very common.
Yes.
Few people are doing, starting with laser, but it's so easy to go by intravitreal injection. What should be the pass-on message?
Sir, actually, with intravitreal injections, there are specific indications of intravitreal injections these days. According to ICROP3 study, so which is recently published, there are specific indications for the intravitreal injections. But otherwise, intravitreal injection should not be taken as the primary treatment. Laser is the only definitive treatment available. But with intravitreal injections, we can buy some time. If the baby is sick on ventilator, baby is in an ICU, so you just give intravitreal injections, and after that advise the pediatrician or advise the parents that child may need, and most of the time in 90% of cases child need laser also. So by giving intravitreal injections, so you can delay the progression of the disease, but you can't stop the progression of the disease. Although there are specific indications, if the disease is present in zone 1 where the laser is not possible, so you give intravitreal injections. So then then there is a spontaneous regression of the disease, then follow that baby. If the baby needs a laser in the peripheral retina, then do laser. Otherwise, the intravitreal injections are basically one intravitreal injection is sufficient to treat that baby. And if there is vitreous hemorrhage, you can't see the fundus of the baby. So even then, or media is hazy because of some other problem like poor pupillary dilatation, then cataract is there. You see that the baby is very premature, then you can give intravitreal injection in that also. But that should that baby should be on regular follow-ups. When the people dilates, the media clears, do laser as and when required, sir. So we can buy some time with the intravitreal injections only.
Thank you, Dr. Karmjeet, for very, very interactive talk. Thank you very much.
Thank you, sir. Thank you very much.
Once again, Doctor, thank you very much, Kamji, for such a elaborate and important explanation of ROP, which is a need of the hour. So, may I now invite Dr. Saurabh Mittal.
As I was telling, it's important to screen these childs, and sometimes we do land up with other ocular problems also during the screening, as this 1 month old child was found to be having that absent red reflex and a white reflex from the eye in both the eyes, was identified to have a pediatric cataract, congenital cataract. So this type of cases also identified and has to be treated. Their timely identification, removal, and rehabilitation is crucial in the growth and development of the child, because the child is one who has so many years of life to be given. If they are not identified timely, their whole life might get jeopardized. Skipping epidemiology, causes of pediatric cataract, we all know. Most important part in history is the age of onset of cataract, if we are able to find out that. And also to identify any maternal infections, because it can be present to the next child who is going to take birth. We should be looking for the additional milestones of the child, and we should also be ruling out any genetic and medications that the child is taking. Also, we should be asking the patient for any external injuries. The most important ocular examination is the Bruckner's reflex. We shine a retinoscope or a ophthalmoscope into the light into the eye and look for the red reflex. If it's absent, we should suspect something is wrong and take it to other ocular examinations and find out what type of disease the child is carrying. And one of them, what we identify, is cataract. And cataract can be qualified into any of these particular categories, starting from anterior polar to posterior polar cataracts. Important to understand is the emetropization stage. We know that the axial length increases from 16 millimeters at birth and keeps on increasing till 13 years of age to around 23 millimeters. Simultaneously, the corneal curvature decreases from 51 diopters at birth to almost 43.5 diopters in adults. This is on an average we are talking about. And to correct both these, the lenticular power, the lens keeps on thinning down and keeps on flattening, and the power keeps on decreasing, so that emetropization of the eye is maintained. So this is very important to understand, because it helps in our calculation of the IL powers, what we are going to insert in cases when the surgeries are being done. So initially, in the first 6 months, the change in the axial length is very rapid at 0.5 millimeters per month. Then it slows down to 0.15 millimeters till 2 years of age, and then it hardly changes around 0.1 millimeter up till 12 years of age. Important investigations include torch screening. If rubella is positive in most of the cases, we should be avoiding, while surgery, we should be avoiding a contact of a female non-pregnant ladies in the OT vicinity, because the torch can be infective, and that has to be taken care of. We should be doing a hemogram so that general anesthesia fitness can be taken. Bilateral cataract should be operated within 2 months of age, and the gap between two surgeries should not be more than 2 weeks. Otherwise, the second eye will become amelogenetic. And if it's not visually significant, we can wait till the child matures in his ocular development, because there are lesser complications if the surgery is delayed up to 4 years of age. Important to note is preoperative evaluation, keratometry, biometry, and IOL power calculation, because they play a very significant role in what we get post-operatively. All kids, their parents are told that the child has to wear a glass after the surgery. This is very mandatory for, as Dr. Dhami has told, in adults. In kids, it's definitely more important, because as they grow old, there will be change in the axial and there will be change in some corneal dimensions. So he might, at today or later, will require spectacles to be worn. And we should be ready for the intraoperative challenges and post-operative complications that might arise due to surgery. So what I follow is Dhan and Rosew's adjustment, where we normally take a SRK2 or Holiday 2 formula, decrease the IOL power calculation, whatever comes in, by 20% till the age of 2 years and by 10% till the age of 8 years. There are so many other adjustments that can be done. One is given by NHID, where the target refraction is taken as a criteria, and every year the target refraction decreases with time. So according to Dan ratio, if we get a calculation of 30 diopters of IOL power and the age is less than 2 years, I normally implant somewhere around 24-25 diopters of IOL. So surgery of choice in pediatric cataract will be phacoemulsification with possible in the back posterior chamber intraocular lens. It can be combined with primary posterior curvilinear capsular axis, or can be combined with limited anterior vitrectomy, depending upon what age we are planning for the surgery. If the surgery age is less than 1 year, what I will plan is lens removal with or without a IOL, with primary capsular axis and limited anterior vitrectomy. Ages 2 years to 6 years, I will be doing a lens removal with a IOL implantation with primary posterior capsular axis and limited anterior vitrectomy. More than 6 years of age, I will be doing lens removal with IOL. I can skip primary posterior capsular axis and anterior vitrectomy, because the child is mature enough to undergo YAG capsulotomy at a later stage. Also, infant phakic treatment study suggested that if we try to put try to push in an IOL less than 1 year of age in a small eye, then there are increased risks of additional complications that might arise, which we have to handle, makes it difficult for us later on. So this is one video of implantation of EDOF IOL in a 4-year-old child. We make corneal incisions, inject phenylephrine, which is tropicamide plus xylocaine, into the eye to dilate the pupil. I use a cohesive viscoelastic to deepen the anterior chamber. I try to make it as flat as possible, the anterior capsule. Make a central nick with the help of a capsular axis forceps. The elasticity of the tissue is such that the rhexis tends to keep on running towards the periphery. So I have to keep on pulling it towards the center to make the circular rhexis, which is somewhere around 5 millimeters in size, so that the IOL stability can be maintained postoperatively. Hydrodelimitation is to be done to try to rotate the nucleus, and as much as cortical matter which is sticking to the bag should be separated. And phacoemulsification is done with a IA setting. We don't need a phacoemulsification. We just need a aspiration with the help of a phaco tip, so that the whole nucleus chunk can be removed. This can anytime come out through the rhexis. So you should be gentle enough to place the IOL inside the bag. And after the IOL is placed in the bag, since this is a 4-year-old child, I will do the anterior vitrectomy. Make a pocket there. This anterior vitrectomy helps create an edge, so that whatever cells are migrating posteriorly, they migrate till the edge of the posterior capsule, and then they follow the path towards the posterior surface of the posterior capsule, and the central axis remains clear. So this is very important, why we make a posterior axis in pediatric patients. So what intraoperative surgical considerations I should be looking for to make a scleral or a corneal incision? I prefer corneal. Use dispersive or cohesive viscoelastic. I use cohesive. Intraoperative adrenaline, whenever I use intraoperative adrenaline, I inform my anesthetist that adrenaline is going to be pushed, so he has to monitor his blood pressures and cardiac status. Using Trifan Blue helps in identification of the anterior capsule better, and so that Rexis can be completed easily. IOL designs, I prefer any type of IOL design, but with experience we'll talk later that I've selected a few designs which they give better results. Posterior capsular access to be done in ages less than 6 years, 7 years. Anterior limited vitrectomy if posterior access is done. And peripheral alloidectomy depends upon what the child, if I am able to place the lens in the bag and the child's eye is normal size, I do prefer peripheral alloidectomy in less than 2 years of age. Later, I sometimes skip that also without complications. And wound should be closed in cases the AC is not forming, because their tissues are very elastic, they can just, the wound can leak anytime. So those who have skipped the anterior capsular rexis in the first thing, I have used this video to show again that how anterior capsular rexis with the Trifine Blue. This is a 3.5 months old child where we had a bilateral cataract, and viscoelastic was used to flatten the anterior chamber. See, the tissues are so elastic that we have to sometimes take a needle to make a hole in the anterior capsule, and it's tough sometimes to make this hole. Once a hole is made, a flap is raised, and then with the help of a rexis forceps, the flap is extended, pulling the rexis centripetally. We don't make it centrifugal. We just keep on pulling it to the center, so the appropriate size of the rexis is made. I think with help of Trifine Flu, I am better able to show you how the rexis can be completed. And we have to keep on pulling it to the center. And we have to be very gentle, otherwise it is going to run away to the periphery. So it was trying to run away, we have to pull it to the center. This is another case of posterior subcapsular cataract. Here we have already completed the surgical part. So after removing the nucleus, after removing the part of the nucleus, we saw that there was a thick membrane which was stuck to the posterior capsule. And it was very difficult for us to remove that rexis with that membrane with help of the regular equipment. So what we did was we attempted to remove it bimanually. So with the help of the Simsky hook, with help of the Simsky hook, we lifted this we can do that also bimanually. We just lift this posterior capsule, posterior membrane, and see how it has to be lifted. And anyway, so we have to take that 15-degree knife and make a stab incision within the posterior capsule, and then use the vitrectomy cutter to make this bigger hole. And we keep on making this hole till we get an adequate size posterior capsulotomy, and then this patient, the eye size was almost normal to the growth. So we have placed the intraocular lens in the, in this case, in the bag. So this rexis was completed. So sometimes what happens is while we are doing the surgery, we tend to catch hold of, sometimes we are very aggressive. We don't want to do the surgery fast enough to complete it so that anesthesia effect wanes off. You just go and catch hold of the posterior capsule and make a rent which is which has to be tackled. So what is done? See, we are the rent is being made. So now what is just stop the panic mode, and start thinking. Otherwise, inject the cohesive viscoelastic. Now we are supposed to. What we are supposed to do is we have to make a rexis out of this tear. Because in pediatrics the vitreous is very solid, so we are easily able to catch hold of the rexis margin and complete this rexis. But since this is eccentric, after placing, we have to make it central. So central can be done with help of either we make a nick in the capsular rexis and then extend again, or what we can do is we can just place a IOL inside the bag and then take a vitrectomy cutter and increase the margins towards the center. So what if we are afraid of doing a axis before before implanting a IOL? It might go in, or it might be difficult for us to manipulate the lens inside the bag, especially in these small kids who are 3.5 months old with small eyes. So what we are supposed to do is just implant the IOL first, take a needle, make a nick in the posterior capsule, then take the retractor and make a vitrectomy, central vitrectomy, and cut the posterior capsule with the help of the vitrectomy cutter. So this will complete the primary posterior capsulotomy, what I say, and the results as needed will be achieved this way also. So either you make a axis before or you make a axis after the surgery, after implantation of the IOL. So which IOL we should be implanting? So first is a no to iris claw IOL from my point of view, because I have seen so many corneal complications with age, which makes the child's, the adults' ocular, whatever we want to give them, the ocular vision function a little bit more complications, and then we have to handle it with corneal grafting and other stuff. So what I feel, acrylic IOL is better than a PMMA IOL. A square edge design helps in reducing the PCO formation. A single piece is preferable if the IOL has to go in the bag, and multi-piece is preferable if the IOL has to go into the sulcus. I've used all these designs, monofocal, EDOF and trifocal, and use of trifocals or EDOFs remains a controversy in adults and also remains a controversy in pediatric patients. But we do definitely go for an implant of a pediatric toric IOLs, even in pediatric patients, if we are very confident about our biometry, which shows that there is a high astigmatism, and we are able to mark that point, because sometimes marking that point at 90 degrees or 180 degrees becomes a challenge in a child who is very uncooperative. So, but if we are able to mark a point in that child's eye, we are able to keep our toric marker in such a way that the point is identified, and accordingly the placements are done. Complications, if there is a wound leak or we suspect there might be a wound leak, we should be putting a 10-0 nylon suture at the tunnel. We should try to decrease the vitreous pressure because it will lead to eventually IOL or iris capture. There might be a vitreous hemorrhage from the surgical PI. That is why I avoid doing a surgical PI if the IOL is in the bag and AC is well formed. Then there is always a possibility of high inflammation and endophthalmitis, which has to be taken care with steroids and antibiotics. Late postoperative complications include formation of PCO, which needs to be dealt with either surgical capsulotomy in younger age groups or a YAG capsulotomy in cooperative patients. Increase in intraocular pressure can happen, and it's usually seen if vitrectomy is not done in very young kids, where there is forward movement of the vitreous and the IOL pushes towards the cornea, and especially with the sulcus fixated IOL, in sulcus fixed IOLs. So there the glaucoma chances are on a higher side. Amblyopia, definitely any of these kids can have amblyopia, which requires a refractive correction. Identification of a proper refractive error like myopia, hyperopia or astigmatism has to be given. Even additional power has to be taken care of. Any addition is required, we should be giving them. Then requires a patching or even vision therapy to improve their visual acuity. So at the last, I would like to say that early detection, while routine screening, examination and investigations are must, the timely treatment should be given to prevent amblyopia, and visual rehabilitation with help of corrective lenses, patching and low vision aids should be given. Thank you. Amblyopia management usually won't need low vision aids. We need proper refractive glasses and vision therapy. Low vision aids are required when there is retinal pathologies along with, so that the image is not getting formed properly. In pediatric patients, the low vision basically needs a higher lens powers. And visual rehabilitation with help of amblyopia therapy first. And if vision is improving to a particular point, and if there is any other pathology, then the low vision aids comes into play, not in routine cases. So normally these cases which are less than 6 months of age do have the history of rubella positivity, or any inflammatory chances are on a higher side, or they are metabolic in origin. I have not seen post-operative inflammation for such a long time. We normally give cycloplegics for 1 week and then steroids for 1.5 to 2 months. And most of them, they do well with this much amount of treatment. We don't have to carry on with atropine for a longer period. Cycloplegic is good enough, cyclopentolate. Thank you, sir.
May I invite the next speaker, Dr. Pawan Prasha, and his management of dry eye post cataract surgery.
It depends upon the diagnostic method, location, sex and age. It depends upon the diagnostic method, location, sex and age. And India at present, it faces an imminent epidemic given its sizable aging population and chronic nature of dry eye disease, and with the changing lifestyle. And individuals aged above 50 or above, particularly males, and this is the cataract population, they exhibit a higher susceptibility to dry eye disease. As per this study, the most prevalent symptoms of dry eye include blurred vision and sensitivity of light, although there are other symptoms also: stinging, burning, dryness, foreign body sensation, some itching, and quite often patient is not able to articulate what exactly is going on. They will complain of heaviness, blurring, fatigue, or tired eyes. And the tube study, the report, it showed that dry eye is a complex interplay of various factors related to where they emphasize on tear hyperosmolarity and the inflammation playing a key role and the various predisposing factors are there. So I'll skip those and come to the iatrogenic dry eye disease related to cataract. So it has been shown that cataract surgery is associated with the onset of iatrogenic dry eye disease by virtue of various maneuvers or which we do while performing the cataract surgery, and the incidence is higher than anticipated, around 42% after. So this is a study where various dry eye related symptoms and signs they studied, and it was found that more than 40% of patients, they complained, developed dry eyes. These are the patients who did not have dry eye pre-operatively in the early post-operative period. The decrease, eventually the patients get better, and after 1 and 3 months, the patients improved. And various pathophysiological factors, they include, in the dry eye, we know, include inflammation, hyperosmolarity leading to tear instability, and its associated signs and symptoms. During surgery, we fiddle with the ocular surface, so repeated drying, irrigating drops, povidone iodine, anesthetics, preservative, eye drops, phototoxicity due to the microscope light, surgical trauma, incisions, and all these corneal nerve damage. So all these factors predispose to post-operative dry eye disease. And the studies have shown that dry eye symptoms are related to reduced tear film breakup time and loss of goblet cells. And this is a documentation of the goblet cell density decreases after the cataract surgery, and tear film height also decreases. So we have a complex interplay of various factors which produce dry eye in the early post-operative period, and unfortunately the surgeon has to bear the burden because patient blames the surgery for the symptom he is facing. So altered meibomian gland functions without structural changes can happen after the post-operative, after the phacoemulsification or any cataract surgery. And diagnosis and management is almost the same as we do for other dry eye symptom, but it is recommended that pre-operatively we should spend a few extra minutes looking at the lid margin health, do a fluorescein staining to detect pre-operative dry eye. Tear film breakup time is very sensitive and very specific for the diagnosis. And Schirmer test in high-risk patient that may help you to document the pre-operative dry eye and take steps and address the pathology pre-operatively so that you have less problems in the early post-operative period. So various measures we can do are pre-operative, like you diagnose dry eye and treat the dry eye before you go in, especially any lid margin inflammation, meibomian gland dysfunctions and so on, and take adequate care while doing the surgery. Try to do minimum damage, minimum drops and so on. And this is what we know, that dry eye has different parts, aqueous, deficient, evaporative and mix. And the diagnostic tests, although there are some lab-based like tear hyperosmolarity, matrix metalloproteinase, but these are not routinely available. So most of the time we depend upon other things like patient's complaints, the adequate history, Schirmer test, fluorescein test, and breakup time. So due to they advocated that we can take various steps like patient education, environmental modification, lifestyle modification, dietary changes, medication review, lid hygiene, and tear supplementation as per the severity of the drug. These work and very well, and depending on the severity, you can pick as per the patient's symptomology and your findings. So this is some basic science research which I will skip in the interest of time. So this uses a stabilized oxychlorocomplex, the refresh group, which is a purite which evaporates on coming in contact with the tear film. So it does not have the side effects of benzalkonium chloride, which is quite toxic to the ocular surface and epithelial cells. And this is a representation how the epithelium heals in the rabbit eyes experimental model. And this is 1% CMC, and it has been shown that it is quite effective in reducing the various symptoms and signs. Breakup time, if it improves after the installation in the routine post-operative period, and it performs a little better than the other comparative polyethylene glycol and sodium hyaluronate and so on. To conclude, dry eye is a chronic multifactorial disease resulting from increased tear film evaporation or decreased tear production. And cataract surgery has been found to induce dry eye in patients with healthy corneas, and it exacerbates the symptoms of pre-existing dry eye. And topical therapies for dry eye include various lubricant drops that contain a mixture of CMC and oxidative preservative, which is friendly to the ocular surface. And adding CMC 1% to conventional therapy after phacoemulsification can help prevent patients from exacerbation of these symptoms and have a comfortable post-operative period. Thank you very much for your attention for now.
So with that, we come to the end of the second session. I request Dr. Roshan Lal, Dr. Chunni Lal, and Dr. Virdi. Please come forward to honor the speakers. I will request Dr. Tami please to come for the honor. Thanks, sir. Thank you, sir. After that, I will request Dr. Karamjit Singh and Dr. Pawan Prashar. Dr. Karamjit, please. Dr. Roshanal. Dr. Pawan Prashar, please. Dr. Sahab. Dr. Pawan. In the meantime, I thanks Dr. Bhora, Dr. Kuldeep Singh, and Dr. Tania for being panelists for the second session.
Good afternoon, ladies and gentlemen. We are running late, so we start straight. We have Dr. Gurvinder Kaur with us, who will speak on the art of interpreting visual fields, an arrow in the quiver. Doctor, the mic is yours.
Thank you, sir. इसमें थी प्रेजेंटेशन तुम उठा के ले गए मेरी प्रेजेंटेशन उठा के ले गए प्रेजेंटेशन So, good afternoon, everyone. So, we are actually running late, and I'll not try to bore you with this presentation. I hope visual field analysis is a very big topic, and I hope to do justice to this topic in this much time. So, the slides are not running there. Okay. So perimetry is a method by which we check the visual fields, and visual field is actually the part of the environment which is visible to our eyes. So it is, everybody knows that what we see is 60 degrees nasally, 90 degrees temporally, 70 degrees inferiorly, and 50 degrees superiorly. So it is actually, our visual field is horizontally oval. So Traquair, he defined the visual field that there is a big sea of blindness in which we have an island of vision. So this is a 3D picture which on perimetries we have tried to reduce the 3D to 2D by the isopter plots. So this is the visual field by 30-2 static perimetries. What we can see is 30-2, the central 30 degrees of the visual field. Whereas if you want to see the whole visual field, you need to know, you need to use the traditional Goldman perimeters which we as residents have used. So I'll not go into these details. I'll try to stick to more practical use of visual fields. So there are many testing, if you have looked at your visual field perimeters, Humphrey perimeter, there are many programs. There's 30-2, 24-2. So what are those? 30-2 is which checks from the fixation point 30 degrees. It has 76 points. 24-2 has 54 points. Because the points are reduced, the time to do the test is reduced. So then there is 10-2. 10-2 is only used if you have advanced glucometers changes where you need to focus on the central 10 degrees of the field. Then you have a macular prot. So out of the 10-2, the central 16 points are used for the checking in macular program. This is usually to see the macular split. Macular split is very important because it is a very bad prognostic sign for trabeculectomy. Then there is 24-2C where to the 24-2 you add on the 10 extra macular points. So we'll not go into these details. So there are many strategies which are available in your Humphreys perimeter. So which one do you use and how much time it takes? So usually what nowadays people use is 30-2 CETA standard. CETA fast is not that sensitive to check the glucometers damage. So we should ideally stick to 30-2 CETA standard or 24-2 CETA standard. So that actually takes about 10 minutes or 7 minutes. So when you select a strategy, initially for screening 30-2 is good. Actually suggest I've done it myself. It is rarely a difficult test. And everybody should actually do this test on himself or herself to realize what the patient has problems in the learning curve. It is a difficult test. So to get the proper fields, we have to patch one eye and then do the other eye. So your pad of one eye should not overlap onto the other eye. Not even the string of that pad should go onto the other eye. These are small things because everything which looks black on the visual field analysis is not a defect. So this is just, I'm not going to bore you with this. What we need to know is on Humphreys, we have some points like 0, 10, 15, 20. So 0 dB means the maximum light which is passed on the perimeter. That's why wherever there is a blind spot, you have 0 there. So 0 is the brightest, 50 is the dimmest. So this, everybody knows, this is a Humphrey field analyzer and report. And when you look at this, please don't see only 3, 4 or 10, 15 black spots and then we diagnose it as glaucoma. It has 8 parts. Each and every part has to be seen. We'll go one by one into all the parts. So zone 1, which is seen on the top of the report, it tells you about the strategy which you has used, 30-2, CETA fast, CETA standard. It tells you about the age of the patient, name of the patient, very important. You cannot compare two different names and on the follow-up. So you need to look at the name of the patient. Age is very important because all these reports are generated by the normative data. They compare your patient's problem with the normative data of that age group. If your age is not added properly, then the reports are not very reliable. So it has, the other things which are, there are stimulus. You can look at this, I can't see the marker there. So there is a stimulus, size is there. Then very important is your pupil diameter, the visual acuity and the refractive correction which you have given. You need to give a refractive near vision correction for doing perimetry and the pupil size need to be adequate. So this is the patient and the test data which is there on the top. Next is your foveal threshold. So if you look at the second part here, so right on the right extreme, the zone 2 is the your reliability indices. So whenever you look at any report, you need to see whether your test is reliable or no. So the fixation losses, the false positive, false negatives, they actually tell you whether you can rely on this or you need to repeat it. Also, there is a foveal threshold, which is a very good indicator of the patient's visual acuity. So if you can look here, the fixation losses, I'll shift it on to this so that I can use the marker. So you can see these fixation losses, more than 20% fixation losses and more than 33% false positives and negatives. They are all marked like this, like a circle, like a cross. So these are not reliable. You need to then repeat the test. So zone 3 is your raw data. So this is what is seen there as numbers. So that really doesn't tell you too much. If you do not want to spend time, do not spend time on zone 3 and zone 4. Zone 3 is the raw data. Zone 4 is this grayscale. Actually doesn't tell anything. Majority of the people look at the grayscale and tell. You should not be looking at this and be judging what it is. So zone 5 is the total deviation plot. There are two plots below. So you have a total deviation plot, you have a standard deviation plot. Total deviation plot, if I tell you broadly, if we do not go into too many details, total deviation plot tells you the overall depression, whereas the pattern standard plot tells you about the localized depression in the visual field. So total deviation plot, it has the numbers, it has these points. These points, if you can look below these points, you have the p-values. These are important because if we look at the Anderson criteria, we need to look at the p-values. We'll talk about this later. Then you have a pattern deviation plot. So if we compare the total and the pattern deviation plot, you can see there are more black spots on the total, lesser on the pattern. When you want to know about the glucomatous change, look at the pattern deviation plot. So this is actually maybe a case of cataract with glaucoma. So the cataract is causing those black areas on the total deviation plot, which are reduced to the glucomatous damages on the pattern deviation plot. So need to look at the pattern deviation plot. So then you have various global indices, mean deviation, pattern standard deviation. Usually if you use the CETA standard, then you will get only two values, the mean deviation and the PSD, pattern standard deviation. Third one is the arcuate scotoma. The fourth one is the paracentral scotomas. So very important, everything as I told on visual fields is not anything which is looking black is not glucomatous. You may have glaucoma, you can have neurological deficits which cause damages on the fields. So a glucomatous damage has a very asymmetrical distribution across the horizontal midline, and it is usually localized between the central mid-periphery. And it is usually reproducible over two consecutive occasions. So this is everybody I think knows the Anderson criteria. It is very important to diagnose glaucoma on perimetry. So one, the glaucoma hemifield test, which is written there, GHT has to be outside normal limits. Then the pattern standard deviation. So on those, this is on 30-2, so you have to have 3 or more non-edge points on which the p-value is less than 5, and out of these edge points, at least 1 point should be less than 1. And if you can just remove they'll be able to see. So you can actually remove that, there's no need. So, and the PSD, MD and PSD which we said, PSD has to be less than, the p-value has to be less than 5%. So if these three criterias are met on 2 consecutive looks, then 2 consecutive fields, then it is a glucomatous damage. So now we look at few of the photographs. So this here, if you see the GHT is within normal limits, the p-values are not less than 5, so it is a normal. 1 or 2 spots on the pattern deviation doesn't say it is glaucoma, it is a normal field. So here, if you see, this is actually the nasal step. Now, how do you see on perimeter what is nasal and what is temporal? Very easy. You don't have to actually juggle your brain for that. The right side, on all perimeters, it's written right eye or the left eye. So right eye perimetry, hold in the right eye. So whatever this is my right eye, this is temporal of right eye. So on the paper, anything seen on this side is temporal of the right eye, nasal of the right eye. My left has to go in my left hand. So left report in the left hand, anything on this side will be the temporal and this side will be the nasal. So you really don't have to actually juggle too much in this. And this is very important when you have to see the neurological deficits. So this is the nasal step. So always concentrate on three things: the pattern standard deviation, the PSD and the MD, and the GHT, the glaucoma hemifield test. These are the three things you have to look after you confirm that this perimetry is of the same patient we are looking at the fundus for. So this is an arcuate, it is an inferior arcuate scotoma. This is a double arcuate scotoma. Always see in a glaucomatous damage, it will not respect the vertical midline. It will actually cross the vertical midline. So this is again a arcuate scotoma. This is an inferior arcuate scotoma, again an inferior arcuate scotoma. This is again going into a double arcuate scotoma, again a double arcuate scotoma. So these you need to look at. Again I'm telling pattern deviation, glaucoma hemifield test, and the mean deviation and the PSDs. So just a slide on, if you can remove my photograph. Okay. So just a slide on macular split. Macular split is very important to see whether to decide for TRAB in cases of advanced changes, advanced glaucomatous changes. Because if the macular split is there, there is a high incidence of washout phenomena after the trabeculectomy. So how do you look? Many people, I also took many ages, after my post-graduation, to actually realize what is a macular split. So on a macular program which sees the central 16 points on 10-2, you look at this gray colored photograph. So on one quadrant, if 1 point is less than 10, it's decibel. So if 1 point is less than 10, and you look at the adjacent point on the other side on the same quadrant, if I can come there. So if you look at, these are the 4 quadrants, and 1 point is less than 10, adjacent to that on the same side, if another point is also less than 10, so this is a macular split. It need not be 0, it has to be less than 10. So glaucoma progression analysis is again important. So for a glaucoma progression analysis, at least you need to have 3 visual fields of the same patient. So these have these, if you can, fixation site. So if the high false positives are crossed and this kind of white appearance is seen on the total deviation and the pattern deviation, it is actually a trigger happy patient. He's just pressing it happily. So false negative, this is the only place where you can look at the grayscale, because that grayscale is telling you a clover leaf appearance. So here the patient is having a false negative responses as high. He can see but he is not pressing. Small pupil, so this is actually the right hand side is a small pupil, and when that pupil was slightly dilated, that's the on the other side. So this is not a arcuate scotoma, this is just a peripheral depression of the fields because the pupil is very, very small. So this is the learning curve. In my practice, we never rely on the first perimetry done by the patient. So you give him benefit of doubt for at least 2 or 3 times. So rely on the third perimetry because it has a learning curve, and after 2 or 3 perimetries, the damages which we were thinking of glaucomatous may turn out to be normal. So these are the rim defects. When you put up, whenever you give a near vision correction, so that lens is put up there, so that can also have the rim defects. You need to see whether it is there or no. Just 2 slides on the neurological deficits. So this is a neurological deficit. This is not glaucoma. This is not double arcuate. Always remember, anything which is neurological will respect the vertical midline. So this is actually a bitemporal hemianopia. It has not crossed the midline. The defects have not crossed the midline. Similarly, in this case, it is homonymous hemianopia. Again here, it has not crossed the midline. It is homonymous hemianopia right side. And last 1 or 2 slides on test. We do not treat the perimetry charts. We treat the patient. So we always need to correlate our perimetry findings with the patient's fundus findings. And humans by nature are biased. So please do not look at the perimetry findings and then extrapolate them to the fundus findings. Treat them separately. So get a perimetry done, see the fundus, correlate them. If those findings correlate, then we can rely on the test, otherwise repeat it. So always remember, tests are secondary, patients are primary. So in this case, if you see nowadays, we have OCT also with us. So the OCT RNFL can also come handy. So in this case, if you see the inferior RNFL is thinned, that correlates to your superior defects in the superior field. Similarly here, the superior NRR is thinned, so that correlates to the inferior defects on the perimetry. So always correlate. Thank you so much.
Thank you, Dr. Gurvinder Kaur. You indeed are an excellent teacher. Any questions, ladies and gentlemen? If there is none, Hanji, please.
Yes, we should not rely on first perimetry. So because they may not have exceeded more than 20% and 33%, but they still there may be 18 or 19. If it is 18, 19% and false negative positive are 33%. If it is about 32%, it will not be flagged off on perimeter. And they do not give it as percentages. They give it as fraction. We never calculate percentage from there. Patients have a learning curve. Everybody has a learning curve. So we should not rely on the first. We should rely at least on the second or third. I usually go with the third for the first patient. In the follow-ups, you rely on the first. Still, sir, first, then it is more indicating towards the defect, but still do not do the first time if patient is sitting on the perimetry. That is just for his experience. You have to follow it up. Even if all the parameters, sir, yes. Sir, it depends. Sometimes if the patients are very old, so first karke they are all very tired. So then you can do it on the consecutive visit. Otherwise, you can give them a break of half an hour or 1 hour and then repeat it on the same sitting. Yes.
Thank you, Dr. Gurvinder. Ladies and gentlemen, I am privileged to present next a very decorated eye surgeons. You have heard about decorated soldiers who win Paramveer Chakkar, Mahavir Chakkars. Ladies and gentlemen, here is a very decorated eye surgeon. He has received the most awards, probably the maximum, at least in Punjab. Jalandhar definitely. He's none else than Sangeet Mittal. And I'm sure he'll live up to the reputation. He is speaking on 2 talks. One is, sounds like a James Bond thriller. James Bond title, Never Say Never Again. Turning retinal challenges into success stories, and the second talk is Dislocated IOL's Different Strokes. I'm sure he'll prove his mettle.
ऑडियो कर देता था ऑडियो कर देता था इसी में नहीं आ नहीं रही इसमें नहीं आ रही इसमें आ नहीं रही चलेगी चल पड़ी नहीं Okay. So this presentation mainly aims at general ophthalmologists. I just wanted to tell the general ophthalmologist to never say never again, because I have seen many times the patient first goes to a general ophthalmologist and then they say, okay, they see the condition of retina is very bad, and they just refuse it. Nothing, कुछ नहीं हो सकता भी तेरा हम तो कर बैठ जा, कोई फायदा नहीं हैगा तेरा कित जान दा. So this presentation just aims to showcase some cases which were conceived which were thought that they won't gain anything, but they ultimately turned out to be success stories. So there are few common misconceptions about VR surgery in the minds of general ophthalmologists. Like one, it is very complex. Definitely it is. But these days with the advanced instrumentation and with the advanced machines that we have, we are able to deal with most complex cases. Then it is expensive. It is not that expensive as you think, because I think now with the higher end IOLs are becoming more expensive if we compare to the total cost of the VR surgery itself. So only the cost of IOL is more. There is poor anatomical success. Nowadays, again, it is not the truth. Almost 90 to 95% of the patients, we get good anatomical success and even good functional success. And the patient, they say, is a chronic patient. भी एक बार VR surgeon को चला गया हमेशा उठे ही रहना है. ऐसा भी कुछ नहीं है. मतलब it is not like that. And the patient, generally, we treat them and we send them back. So few cases to showcase how these poor prognosis cases that were thought to be were treated, and they gained good vision and they had better results. So this is the first case. 42 years male was attacked by a leopard, and when he presented with the vision of query perception of light. He had a perforating eye injury. He had vitreous hemorrhage, total RD, which was closed funnel, which was confirmed on B scan, that is was a RD with closed funnel, and he had a 360-degree giant retinal tear. So this was the patient. So this was a patient. He had this posterior scleral tear, and first step we repaired this scleral tear, and we are using a non-absorbable suture because you don't want here a absorbable suture which will survive for 2-3 weeks, and then we are not able to do the VR surgery. So 2 weeks later we took the patient for a retina surgery, and after clearing the vitreous hemorrhage, you see the whole of the retina is clumped together and there is a big giant retinal tear. So at this point, even VR surgeons like me were afraid, why I started this case first. But certainly if you persist and you try to cure the patient, all these membranes were removed one by one, first the subretinal membranes and then the preretinal membranes. And once all these membranes were removed, you see, now the optic nerve head became visible. And then we used a heavy perfluorocarbon liquid to flatten the retina at this stage.
Once the optic nerve head was visible, heavy perfluorocarbon liquid was used to open the funnel and flatten the retina.
You see the retina opening up now. And then the retina was fixed. There was a chorioretinal scars were achieved using endolaser. And here the laser was done, and then a PFCL silicone oil was used as a tamponade in this case. This silicone oil was removed after 3 months. And the patient got a best corrected vision of 6/36 post-operatively. This is with the oil. And this is 3 months post-operative. At this point, the oil was removed. Then we are using a dye which is called the brilliant blue dye, and we are making inverted flaps of the internal limiting membrane. And this ILM was placed over the macular hole. In this case, we did a large giant ILM peel. We wanted the maximum traction to be released. We did a giant ILM peel, and then we used PFCL, and once again under the PFCL we overlaid the flaps again over the hole. Because the hole was large, we didn't want that these flaps should get displaced. We are using PFCL, and then fluid air exchange was done. PFCL was removed and gas was used as a tamponade. And this is 3 weeks post-op. You can see the hole has closed and the vision had improved to 6/36. So leave alone smaller macular holes which can be easily treated. Giant macular holes can also be treated nicely, and patients do get a good vision post-operatively. And so there is, I would advise, like if you see a macular hole, ask the patient to immediately come, because sooner the patient gets operated, the better the recovery it is. So this is another case, 75 years male, expulsive hemorrhage which happened during cataract surgery. He had a vision of PL plus, PR inaccurate. He had a vitreous hemorrhage, total RD and total subretinal hemorrhage. And again, though the patient was referred in this case, but again it was a tough case and we should not lose hope even in these type of cases. So this is a 27 gauge vitrectomy we are doing, and we have started doing a 4-port pars plana vitrectomy in this case. And you see there was vitreous hemorrhage was removed, there was a total RD, and there was total subretinal hemorrhage below the retinal detachment. So once this hemorrhage vitrectomy was completed, a retinectomy was done. First a small hole was made and bulk of subretinal fluid was removed through this hole only. Then the retinectomy was extended, and more of the subretinal hemorrhage, there were big clots you see below the retina, and all this, it takes a lot of patience to remove all them. And this patient I think I took 2 to 3 hours just to remove this blood which was present subretinally. And once this blood was removed, again PFCL was used to flatten the retina. Then laser was done around the retinal breaks and the retinectomy side, and silicone oil was used as a tamponade. And this is after 4 months, the retina was attached, and the patient's vision had improved to 6/36. At this point, the oil was removed, and after removal of oil, the patient's vision had improved to 6/18. So even when we think these kind of expulsive hemorrhage can also be taken up if the patient is referred to early. And this is my last case, 48 years female, PDR with tabletop TRD, and best corrected vision was PL plus PR accurate. And these type of cases generally even the retina surgeons try to avoid, because generally they thought that once this is done, nothing is going to happen. So this is one female who had this tabletop configuration of retinal detachment, and she had a vision of PL/PR. She was refused actually surgery at various centers across North India, and she came and she was operated. We did a bimanual surgery again, and slowly these membranes were dissected from the retinal surface. You see the retina below is detached completely. And in this we are not using even very sophisticated instrumentation. I'm just using a 25 gauge 1-inch needle to dissect this membrane. So I don't want like all these retina patients, all these diabetic patients to reach this stage. So they should be referred actually early so that proper treatment can be insinuated early. But even if they reach this stage, still we have some hope and we can get good vision out of these patients. So slowly all these membrane was made free from the retina, and then it was excised. And you see there is no retinal break even which was caused during the surgery, and this is post-operative. Patient gained good vision of 6/18. Thank Thank you. So in the end, just the message is like whenever you see a retina patient, just don't say never that nothing can be done. Just ask for a second opinion at that point. So now going to my second talk, I think more of the interest of general ophthalmologist. Sometimes this is a complication which happens most commonly we do come across, and so all these dislocated IOLs, now we have a wide array of IOLs which we were talking since morning. We had seen so many different types of IOLs and positioned into the sulcus and dialed in its place. So this way you can use if the capsular support is there, you can use the remaining capsule to post the IOL. So this is another way used for thin haptic IOLs, like these 3-piece IOLs. So you make these small flaps, scleral flaps, 180 degrees apart, and you make a sclerotomies under these flaps. This is done around 2 to 2.5 millimeters behind the limbus. Then with a microforceps, you just hold the haptic at its tip and bring the haptics out from these sclerotomies. Then 2 tunnels are made at the edges of these pockets. 2 pockets are made at the edges of these flaps, and the haptics are buried into these flaps, and these IOLs can be actually, you close these flaps using the fibrin glue. You can even use sutures. So it's not necessary that you have to use the glue itself. You can use sutures also. So this is how you can fixate these thin haptic IOLs. So this is sometimes nowadays we sometimes use Yamane scleral fixation, and this is again used for thin haptic IOLs. This was a patient, 59 years male. He had undergone vitrectomy and scleral buckling earlier, and he had an extensive conjunctival scarring. He had a dislocated PMA lens, and so what we did in this case, this is not moving forward. The slide is stuck. Acha, aage. Theek. So this is we used a finesse loop here in this patient. So in the last also we saw how we sclerally fixate these lenses. Sometimes we make this marks, and this is 2 to 3 millimeters of scleral tunnel was made around 2 to 2.5 millimeters behind the limbus, and sclera was entered, and this is the normal trocars and cannula system which we have in vitrectomy, sutureless vitrectomy systems nowadays. And so both sides this tunnel was made, and then we use a finesse loop. This loop we have with us for ILM peeling, we use in our vitrectomy surgery, and this loop was then used to engage the haptic, and then this haptic was brought out through these tunnels. You see, there was a lot of scarring of conjunctiva. It was not we are not able to actually dissect the conjunctiva in these eyes, and both sides the haptic was brought out, and then cautery was applied, and the haptic was slightly kinked so that it does not go back again into the. So the cautery was applied to decrease the haptic to a required size, and then it was slightly kinked so that it does not fall back. And this is sutureless closure was done again, and this is 2 months post-op. The lens was stable. So this is sometimes you have IOL which has damaged haptics, and you have to exchange the IOLs. And this you see in this patient, this haptic was damaged. We have to remove this IOL, and we have to place a new IOL. So what technique I use, like sometimes we use this, again we make these flaps, and now you can scleral fixate it. I take a needle, just go inside this under these flaps, bring the needle out from the main incision, and you thread the haptics into the lumen of this needle, and then you bring the haptic out. Simultaneously you insert the IOL inside and keep the other haptic out. You don't have to send both the haptics inside, And once this haptic is out, similar procedure is repeated on the other side. So this way you can bring both the haptics out, and again you can use glue or sutures to finish off the case. Another to interior in the second eyelet, and then bring out this suture from the inferior sclerotomy. Again, this procedure is repeated on the other side also. And here, once all the sutures are out, you remove these cannulas and then you tie the knot and adjust the centration of the lens. And then you complete the knot and you bury the knot inside the eye. So there will be no irritation post-operatively. So this is 2 months post-operative, the same patient who was done. And this was another 55-year-old male with history of injury, had undergone keratoplasty earlier for corneal injury. He was noted to have a dislocated IOL after 2 months of keratoplasty. And Rayner type C-flex broad haptic lens was there. So only way out was like you have to remove the graft and you have to do IOL exchange and then regraft. But then we thought like we'll just try to refixate the same lens. And this was the lens. And again we tried to glue fixate it. We brought the haptic out and then we cut the inner part of this haptic so that only the outer thinner part remains. And you see, if you have seen these lenses, there is a small hump in the outer part of this haptic, which generally lets the IOL stay in its place. It won't fall back. But again, you bury this haptic into the pockets which can be created at the edge of this tunnel. Again, you bury the haptic again there. And then you close the flaps with the glue. And this is like 2 months post-operative. The patient's vision had improved to 612. The IOL was in place and the corneal sutures have now been removed. So this is last video. I'll show, if you have nothing else, how to do a secondary IOL just by using your lens, which is mostly present in your inventory. So this is the Rayner C-flex type lens which is there, and you have to do a secondary IOL. You can't do anything. So this method, you can even do a secondary scleral fixated lens using this IOL. So you take this lens, just pierce this lens haptic using a 26 gauge needle, use a Prolene suture. I am using a 50 Prolene suture. On both ends, use cautery to create a one flange, second flange on the other haptic, and then you insert your needle here, then bring out the needle through the main incision, thread the suture out on both the sides. On both the sides, you bring out the suture, and then you insert the IOL in place. Then you position the IOL, and now you create another flange on both the sides. So this is a 4 flange technique of using IOL, and you can use your normal Rayner C-flex lens. You can easily fixate them. Thank you.
Simply amazing, Dr. Mittal. Any queries? Thank you so much.
Thank you, sir.
Have you noticed the maximum number of speakers, which is the surname which comes up maximum in today's meet? Mittal. So we have another decorated Mittal who's a hero in his own right, in his own field. Can I invite Dr. Raman Mittal to please speak on oculoplastic surgeries, when to time them. And he's the last Mittal of the day.
Last of the Samaritans, you can say, right, sir? Yes, go ahead. Good afternoon, everybody, and what a wonderful introduction from Dr. Sangha. As I always appreciate him, he puts life into any dead session, but of course this session was not dead, And it's always difficult to follow Dr. Sangeet, and somehow I get chance only after Sangeet speaks. So it is like, James Bond के बाद अगर अक्षय कुमार को एक्शन के लिए भेजा जाए तो भी बात नहीं बनती. So, job about oculoplastic surgery, because when I entered there was hardly anybody doing it and not many people were aware about it. Now I feel it's my duty to inform them what is the right time for the patient to be taken up for surgery, or if somebody cannot do it, at least to refer them to the right place, because otherwise there's unnecessarily delay in the management which is being offered. As most of the times I'm still asked what all is being covered in plastics, so there's always this slide which I show that it consists at least of lacrimal system, lids and adnexa, the ocular surface, the orbit, and the oncology part of it. And nowadays aesthetics is formed a major part of oculoplastics as well, ocular as well as facial aesthetics. The most common entity still remains the lacrimal system related pathologies and concerns. So in this, sometimes we keep on giving unnecessarily the lubricants, the antibiotics, and many other things which are actually not going to resolve the pathology. So we should try to reach onto the diagnosis, if possible, by doing a timely syringing and then refer the patient. Coming to the children, as I was told that pediatricians are coming, so I wanted to put up this slide that congenital nasolacrimal duct obstruction is a very common entity. The best time to do a probing for the child is at around the age of 8 months till about 12 months of age. That is the best time. Before that, we can obviously ask the patients to keep doing sac massage, the Krieger massage, and putting antibiotics, because 60 to 70% of the patients get resolved. But allowing them to wait further is of no concern. This picture actually was showing that a child of even less than a month sometimes has to be taken. Unfortunately, this video is not playing in PPT. This is being shown that this child was not allowed to wait till around 6-8 months of age. Rather, I took this child for surgery, aspirated the sac, aspirated the abscess, pus from the sac, and then did a probing at the age of about 25 days, and the child was relieved. Otherwise, he was having breathing troubles as well. In many other pathologies, sometimes we patients may come to our clinics complaining of watering, and we keep giving them lubricants, anti-allergics, and whatnot, without giving emphasis to this small hole which is called punctum. Sometimes there are punctal stenosis, eversions, and whatnot. And a simple procedure of punctoplasty, by increasing the size of the punctum by doing a 3-snip procedure, elevates the symptoms and the patient is relieved. So timing is important, and you should know what to do it rather than just loading the patient with lubricants. Syringing is very important part of lacrimal system assessment. Most of our colleagues are, of course, intraocular surgeons like cataract surgeons, vitreoretinal surgeons, and whatnot. But there are two schools of thought about the sac syringing. One school says that every surgery which is to be done, intraocular surgery, should be preceded by a syringing test, which is important. But one school of thought thinks that no syringing should be done. Only regurgitation of sac should be performed, and if there's no regurgitation, go ahead with the intraocular surgeries. I think that when in doubt, you should do a syringing test, or at least do a dye disappearance test, which will show you how rapid the dye is disappearing from the cul-de-sac, giving you an idea about the patency of the nasolacrimal duct. Because regurgitation test may not be rightly done, and it may give you a misconception, misinformation. So when in doubt, I would suggest do a sac syringing and get a DCR done before any intraocular surgery, whatever it may be. Otherwise, you may burn your fingers. Sometimes the syringing is not patent, but the patient is having a bicanalular block. In this scenario, of course, you can go ahead with cataract surgery or intravitreal surgery or whatever. But the patient will later come to you with problems of watering, and then you will have a problem. So these are the options for bicanalular block. CDCR with Jones tube is not much preferred nowadays. Trephinization in case of distal canalular block. Otherwise, a simple technique of Botox injection, the lacrimal gland helps. Second, and the very important thing which is there and which really burns my heart is when a ptosis patient is told ਕਿ 15 ਸਾਲ ਤੋਂ ਪਹਿਲਾਂ ਜਾਂ 18 ਸਾਲ ਤੋਂ ਪਹਿਲਾਂ ਨਾ ਤਾਂ ਕਿਸੇ ptosis ਨੂੰ ਹੱਥ ਨਾ ਲਾਉਣ ਦੇਈ। ਬਈ ਜੇ ਤੁਸੀਂ ਨਹੀਂ ਲਾਉਂਦੇ ਤਾਂ ਕਿਸੇ ਹੋਰ ਨੂੰ ਤੇ ਲਾਉਂਦੇ ਹੋ। ਉਹ ਬੱਚੇ ਦੀ ਸਾਰੀ ਜਵਾਨੀ, ਬੱਚੇ ਦਾ ਸਾਰਾ ਬਚਪਨ ਸਿਰਫ ਇਸ ਲਈ ਗੁਜ਼ਰ ਜਾਂਦਾ because somebody out of our colleagues would have said do not get the ptosis touched before the age of 18, which is wrong. The best age for ptosis correction is preschool going age, before the child is allowed to go in school, before the child is smart enough to understand that he is having some pathology, because before that the child is within the lap of the parents and he or she is protected. Nobody dares to call, say that ਤੇਰੀ ਅੱਖ ਕਾਣੀ ਹੈ, ਤੇਰੀ ਅੱਖ ਨੀਵੀਂ ਹੈ, but as soon as the child enters a school, ਨਿਆਣੇ ਇੱਕ ਦੂਜੇ ਨੂੰ ਛੇੜ ਦਿੰਦੇ ਆ, and there is a lot of damage to the mental development of the child. So this is a misconception that the child has to wait till adulthood for the ptosis correction surgeries. 3.5 to 4 years is a very good age. This message I would like to convey to my colleagues, and I would like that please do not let the patients wait unnecessarily unless the parents themselves want not to be done. And there are exceptions. Even this child of age around 1 oval, and believe me, for the last 20 years, none of the patient has come back for that free surgery. The patient has come back for that free surgery. So everybody with some care and efforts do well finally. Not only on the lower side, but on the higher side also. Ptosis, again, sometimes it's said that the patient is old enough, 80-90 ਸਾਲ ਦੇ ਹੋ ਗਏ ਹੈ, ਹੁਣ ਇਹਨਾਂ ਨੂੰ ਕੀ ਆਪਰੇਸ਼ਨ ਕਰਾਣਾ, ਇਹ ਨਾ ਹੋ ਜੇ, ਉਹ ਨਾ ਹੋ ਜੇ. You think this gentleman who is having senile aponeurotic ptosis, with such a deep and severe ptosis, so difficult for him to always pull efforts on the eyebrows to open the eyelids and sometimes to do a chin up position at that age. So senile aponeurotic ptosis, very well done by doing an LPS resection or plication, gives a wonderful result. So age is no bar, whether on the lower side or on the higher side. It is the indication and it's the importance what is there for the surgery. So surgery should be done in a proper way and you can have wonderful results. This is again another senile aponeurotic case. Coming to a variant of ptosis is blepharophimosis syndrome. Again, in this, it's not only the vertical fissurite which is narrowed, but also the horizontal fissurite. Here, of course, I tend to wait for some years because I need some facial maturation before I really increase the size of the fissure, because you have to give a horizontal as well as vertical fissure improvement. So you can see from this position, you can bring the child to this position. And again, it should be done in the childhood itself, not in the adulthood, because of the mental development of the child, which is very important. Facial nerve palsies, our neurologist friends come across, but they refer us for the watering part, for the exposure keratopathy parts. So rather than waiting the person to have ulceration and then doing something for it, we can do so many things. Simple enough, we can do a tarsorrhaphy, but if it is a temporary case, where you can remove. But if it's a permanent, tarsorrhaphy is no solution because it gives a one very ugly fold. We can do gold weight implants, which are very comfortable to the patient and they allow the patient to close the lids well. The implants are surgically implanted within the layers of the lid, and then there is a good closure of the lid. Very common entity, entropions, the lashes rubbing onto the cornea. You think of ourselves like when there is even a one lash falling into the eye, we feel so much of foreign body sensation. And think when there is a huge and the complete lid going in, so refer the patient as soon as possible. Entropion can be corrected at any stage. Very good results. Lower lid entropion, this is the upper lid entropion. Any intraocular surgery should not be done before taking up the patient for a entropion correction surgery. In paralytic ectropions, again, unnecessarily delaying the surgery won't help. We can do many things, ectropion corrections. We can do medial canthoplasties, conjunctivoplasties to give a good result, which will help the patient to resolve the epiphora, cosmetic appearance, closure, and whatnot. And even if you are planning an intraocular surgery. So why not to refer the patient in time so that he or she can be taken care of. Similarly, if it's not a paralytic but a cicatricial ectropion, generally encountered if it is a traumatic case or it's a post roadside accident. Initially, of course, we need to wait for the scar maturation for about 2 to 3 months, maximum till 6 months, and then we should be doing a skin graft. But if the cicatricial ectropion is enough severe that they are causing exposure keratopathy, then you should plan a surgery well in time rather than waiting for the scar to mature. You may need to do a repeat surgery, but it is still okay rather than losing the eye before you are too late. So skin graft done here. I took the skin graft from the other eyelid and did it. You can see a wonderful closure, and there is lid for the lid margin is very much opposed to the globe. Sometimes you lose the part of the lid, and again, as Dr. Sangeet said, never mention, never say never. You don't think that if it is lost, nothing can be done. ठीक है जी, आँख ਨੂੰ कोई problem नहीं, cornea expose नहीं हो रहा, तो कुछ ना करो. We can do lot many things. We can do a lid sharing procedures. We can do a cutler beard. We can do flaps and whatnot, and give a very good effect. This is very important, and most of us know that canalicular tear are very important, and they should be taken care of in the very initial go. If you have a lid tear which is a full thickness type and it is medial to punctum, please suspect a canalicular tear and do it. Either you do it by yourself or you refer it to somebody who can do it. Both upper and the lower canalicular needs to be repaired. If it's only one canaliculus which is gone, do not think because the other one is taking care of it, you need not repair. This is just like कि किसी दी एक अख हैगी दूजी अख ਨੂੰ कुछ हो जाए तो कुछ नहीं होता, रब ने दूजी अख ते ਦਿੱਤੀ है, रहन ਦਿਓ एक अख ਨਾਲ ਹੀ ਗੁਜ਼ਾਰਾ ਕਰ ਲਓ. That should not be the thing. Both the canaliculi should be given equal importance and they should be repaired well. This is a complete talk in itself. I'll just carry on the important points. That do it under magnification, find out the proximal as well as the distal end, and put a mini Minoka, which is not so very expensive. You have an oro stent. I have no financial disclosures to be made. Very not so expensive. I think hardly 2,500 to 3,000 rupees. You can put it. It snugly fits into the punctum, and then you can put it from the punctum, bring it from the proximal. Lid tumors again should be very timely encountered, because if we delay them unnecessarily, we are increasing the size of the tumors, and if they are cancerous, the larger the tumor, the largest area needs to be excised and larger reconstructions needs to be done. If we do it in the initial go, a direct closure can be achieved with a very gratifying result. Similarly here, the principle remains that you should do a clear margin excision taking 3 to 4 millimeters beyond the clinically evident tumor. Do it a full thickness excision and close it well. This is the basal cell carcinoma. You see such a huge tumor, and I had to remove the whole lid. But believe me, if you do well, see this post-operative, post-reconstruction, hardly you can see that this lady had undergone such a huge excision. If I would have shown you, this whole part was excised and was reconstructed. Similarly, this lady, again, basal cell carcinoma, advancement flap was done. Later on, she had wonderful result. No scars, nothing of the sort. Xanthelasmas, small lesions, skin people do it, but they do TCA only. We should be doing excision and closure, gratifying results. Otherwise, they land up into large xanthelasmas. So there's no point delaying the things. That's what I say. Timing the surgeries are important. It's important for the patient and for you to give good results. These festoons are difficult to treat, but it's not impossible to treat. Very good results. Otherwise, you may say कि चलो जी उम्र हो गई है ऐसे होना ही है. There's nothing like that कि उम्र हो गई तो होना ही है. There's so many things which can be taken care of. Of course, this is again umar-related things, age-related thing, bags of fat, but even young adults have it. And we can not only remove this bag, but can also tighten it. If, again, you delay it, it can become large enough to pull the lids down, to cause the eversion of the punctum, cause watering and ectropion. So why not to take them initially? This lady came to me with the reference of ptosis, but what she had was broptosis as well as blepharoptosis. So I did broplasty as well as blepharoplasty and was taken care of. Ptosis was not required. And this unfortunate guy was thought to have entropion, and he was operated thrice before he came to me. His whole lid was given in so many nicks but actually what he had was severe broptosis, and his skin was rubbing into the eye, and the lanugo hairs were the one which are the culprit. So doing a good blepharoplasty and broplasty raised his lids. So he didn't ever needed entropin correction, what all he needed was a good broplasty. This again very important thing. Sometimes very small lesion which may mimic small conjunctival cysts or conjunctival actinic keratosis or some spots on the conjunctiva, but could be neoplasias, should be referred in time or operated in time. Could be conjunctival intraepithelial neoplasia or squamous cell carcinomas. I'll run through the slides that these are smaller ones, removed completely with conjunctival graft. Good results, eye can be salvaged, vision can be salvaged. But if you delay it, it may go and invade into the orbit. Once it invades into the orbit, the most important thing which we need to do is exenteration. So you can lead to exenteration of a patient if you delay. This patient had orbital extension, but it was restricted to anterior orbital margins only. So we tried brachytherapy on him, and he was salvaged for so many years. Orbital tumors, again, initially she did not appear, but when it was a marriageable age, when she was rejected by few, then she came and we did remove our orbital tumor, giving her a symmetrizing appearance, and the proptosis was resolved. Why should we wait for somebody to deny you marriage and then only you get your things done? Like even for LASIK surgeries and for tumors, for ptosis, most of you would have also encountered that ਸ਼ਾਦੀ ਤੋਂ ਪਹਿਲਾਂ ਜਿੱਦਾਂ ਕਹਿੰਦੇ ਨਾ ਘਰ ਨੂੰ ਲੀਪਾ ਪੋਤੀ ਕਰਦੇ ਆ ਤੇ ਆਪਣੇ ਆਪ ਨੂੰ ਵੀ ਲੀਪਾ ਪੋਤੀ ਕਰਦੇ ਆ ਕਿ ਹੁਣ ਇਹ ਵੀ ਠੀਕ ਕਰਾ ਲਈਏ ਉਹ ਵੀ ਠੀਕ ਕਰਾ ਲਈਏ ਵਿਆਹ ਦਾ ਟਾਈਮ ਆ ਗਿਆ ਉਸ ਤੋਂ ਪਹਿਲਾਂ nobody is bothered. So we should not be doing that. I think we should get it done as soon as possible. Otherwise, the tumors become very large, and even if you remove the tumor in toto, there is a lot of blemishes which are left because there was such a huge tumor and the eye went into inophthalmos after the removal. Otherwise, it was so much of severe proptosis. Orbital fractures we come across day in and day out, and to my surprise, even sometimes till date, many of my colleagues ask, Raman, tu tumor fracture bhi kar lena yaar. So I think I fail myself and I fail my all colleagues that I have not been able to make them aware that yes, we oculoplastic surgeons are much better than maxillofacial surgeons in taking care of orbital fractures at least, because muscle entrapments is one thing which they don't touch. So we are the ones who are very comfortable with ocular tissue handling and muscle tissue handling. So they can repair the maxillas, the zygomatics and the foreheads and whatnot, but they don't venture into the orbits where we can. So indications of surgery in blowout fractures is if the patient is coming up with diplopia, with inophthalmos, and sometimes we need orbital decompression to salvage the eye. So if you have a patient who's having a fracture, a subtle fracture, small fracture, no diplopia, no inophthalmos, you can treat the patient on a conservative management line. No need to refer. But if the patient is having diplopia, which is not resolving the eye, so what I did was remove this muscle from the fracture side, put an implant in, and now you can see that superiorly the eye is moving up with no diplopia. Orbital abscess, initially the child was with pediatrician, he was giving IV antibiotics without thinking that a simple nick in the abscess would relieve the patient of this. So a simple nick in the abscess, draining of the pus would also help the antibiotics to work. So timing again of the abscess removal is important. Similarly and very importantly for retinoblastomas, as Dr. Karamjit has also mentioned and Saurabh has also mentioned, in children the age to live is long, so anything which can lead to blindness should be taken care of. Retinoblastomas are well treatable. We can not only salvage the life, the eyeball, but also the eyesight of the child if treated well. Otherwise, he or she may land up into these type of things where extraocular extensions are there, and then you can't actually, you can just delay the death. The child is going to go into death. These are like after PTT, the tumor shrinks and the patient can have good vision, but in this stage, the eye will go into thicycle and nothing else can be done. But afterwards, giving him custom prosthesis, like in this child, both the eyes had to be enucleated and both the eyes are having prosthesis, no vision, but only cosmesis. But cosmesis is also important. Like this girl stopped going to school because her eyes were not looking good. And when we gave her good custom prosthesis, she was able to go to school. So again, not only delaying it till she will get married and somebody will reject her for her bad looks, why not to get her done in age early enough? And let me tell you that even children with inophthalmos or absence of eye, we should treat them from the very beginning, from first month of the age. Otherwise, the sockets will get contracted. we should start improving the socket size. I forgot to add that slide. I'll put it in my slide for future references. That initially, if we start increasing the socket size, then we can give a good prosthesis later on. Otherwise, it will be a permanent contracted socket and we can't do much. In adults, if the socket is contracted, we can do a dermis fat graft, we can give socket reconstructions, and then we can do a prosthesis. But if you do a good evisceration, enucleation in the very beginning, you may not land up into contracted socket. Again, a good surgery, a timely implant is important rather than leading into a complication, then treating the complications. Cryptophthalmos can be treated. You may have a good eye beneath it. Otherwise, the child will have a dense amblyopia later on, and even if you show the eyeball, the vision will be compromised. In thyroid eye disease, initially you can treat this patients with steroids. With good intake of steroids, the eye can become symmetrizing without any squinting or diplopia. You see here she had a huge squint. But if the patient becomes fibrotic, then again you can't do much about it. So timing again here is important. Small unwanted growth should be taken off in time rather than making them increase large. This recently I have many referrals and people get MRIs done and whatnot. It's a simple orbital fat prolapse. If you push this fat, the yellowish structure, you will see it's disappearing within the orbit. It's very mobile. So it's simple orbital fat prolapse. It is separate from the lacrimal gland, and it can be, there's a septum fascia which gets loose and the orbital fat prolapses. So you open up the septum, remove the fat, and cauterize it and leave it there. Wonderful cosmetic result, as well as, of course, the patient is seeing within few weeks only the patient is fine. This is very well differentiated from lipodermites, which are generally present since childhood. Whatever age the child is comfortable. Here you can delay for the cosmetic reasons because this is not so visible. But again, why to wait till the marriage is due? We can remove this lipodermoid, do an amniotic membrane graft, and with good results. Botulinum toxins and fillers are another thing which has come up into cosmesis. These tear troughs can be treated well in time with fillers, and if they increase enough, then we'll have to go in for a surgical intervention to do blepharoplasties. Again, timing here, we can give good cosmetic appearance. So just to tell you, time is important. Here also, time is important, so I'll cut it down here. Thank you very much for your patient hearing.
Thank you. Dr. Raman, you have left us breathless. Fast forward.
So please breathe in, breathe out.
ਉਹਦੇ ਪੰਜਾਬੀ ਚੈਨਲਾਂ ਤੇ ਨਿਊਜ਼ ਆਉਂਦੀਆਂ ਕਿ ਇਹ 1 ਮਿੰਟ ਚ 30 ਨਿਊਜ਼ ਉਹੋ ਜਿਹਾ ਚੱਲਿਆ ਤੁਹਾਡਾ
ਸਾਈਕਲ ਕੀ ਕਰ ਸਕਦਾ ਅਦਰਵਾਈਜ਼
ਥੈਂਕ ਯੂ ਸੋ ਮਚ ਵੀ ਆਰ ਪ੍ਰਾਊਡ ਆਫ ਯੂ ਐਂਡ ਜੇ ਇਤਰਾਜ਼ ਨਾ ਕਰੋ ਆਈ ਵਿਸ਼ ਟੂ ਗਿਵ ਯੂ ਅ ਨਿਕਨੇਮ
ਪਲੀਜ਼ ਡੂ
Mittal the magician.
So nice of you. I'll take it as a compliment. Thank you so very much, sir.
And any queries?
अदे मेरे दोस्त थोड़ा खान च व्यस्त सीगे तो मैं कहना I have to take them again. Thank you. Still, thank you so much.
Dr. Mittal.
Thank you for the stage.
Ladies and gentlemen, we have another ophthalmologist from the same city from which Dr. Raman Mittal comes. He's a gentleman ophthalmologist.
Just like the previous speakers, Dr. Sangeet and Dr. Raman, the topic, the aim of my presentation is more less of technical or surgical details, more of a social message to the comprehensive ophthalmologist or people who are not too much into cornea. That timely referral is the key. So therapeutic keratoplasty by definition means replacement of a diseased host cornea with a full thickness donor cornea to eliminate the infectious disease focus. So routinely performed for non-resolving microbial keratitis such as bacterial, fungal, acanthamoeba, viral, or any other atypical keratitis. So TPK is performed to repair anatomical defect or perforation or descemetocele is also known as tectonics. And quite often the definition, it overlaps. Sometimes we have to do everything together. So goals of TPK include surgical debridement of the infective tissue, elimination of the microbial load. Quite most important is to maintain the globe integrity, and also it generates the tissue, the corneal tissue which we take out, we can send it for histopathology or microbiology and to get a diagnosis, to provide visual rehabilitation if possible. And rejection here is the last thing to worry. We want to save the eye first and then worry about rejection or visual rehabilitation. When to perform? So if you have a ulcer like this, with some scattered infiltrates, then obviously you want to go with the medical therapy. When you have a condition like this, which is progressing despite your best medical management, then you can maybe or maybe not. Quite often I am little aggressive, I go on the side of saving the eye than to wait. And here, when you have a perforation or impending perforation, you don't have, it's not more a medical case, you have to do a surgical intervention. So indications of therapeutic keratoplasty include refractive ulcer, corneal perforation, impending perforation, when the infection extends up to the adjacent sclera, and to decrease the risk of endophthalmitis. Various risk factors include large ulcer size, presence of hypopion, infiltrates involving posterior 1/3 of the cornea, where the antibiotics may not penetrate rapidly or well enough to have a therapeutic effect. Rapidly progressing or fulminant ulcers, and fungal keratitis, because they do not respond well to medical therapy. Various types include full thickness, tectonic, patch graft, therapeutic PKP. These are some of the slides. I'll skip pre-operative and so on into the interest of time. It was a video here. So this is a 47-year-old female with fungal corneal ulcer in right eye for 6 weeks. So not responding to the treatment. So you go in and do a therapeutic PKP. You aspirate the hypopion so that you get a good feedback about the size of the infiltrate. Then we use a trifine slightly larger than the size of the infiltrate, 0.5 to 1 mm. And then sometimes the infiltrate may be limbus to limbus, but then you have to do a conjunctival peritomy and so on. You make a stab wound to enter into the anterior chamber, inject viscoelastic. With a scissor, you take out the infective, this thing. I can't make it run faster. Anyway, you make a trifine, and then it should involve like 0.5 to 1 mm of the normal cornea. You don't want to leave infectious focus behind. So once you later on, and once you have done your best, you make a 0.5 to 1 mm larger donor corneal button, and this is sutured to the host bed with whatever techniques you use. For infectious cases, it is recommended that one should always use interrupted sutures. So first we use 4 cardinal sutures, and then so unfortunately I can't run it faster. Anyways, I'll skip it. This is a surgical treatment. That was not the message. So the patient, most of the eyes can be saved by timely intervention. Post-operatively, we try to take care of the patients in terms of preventing recurrence of infection. So continue antimicrobial therapy. Do not start steroids for 2 to 3 weeks till such time you are confident कि यार infiltrate दोबारा नहीं आने वाला, ठीक है? And then intraocular pressure. Lot of these patients will eventually get glaucoma. So glaucoma, anti-glaucoma therapy is very important. Large grafts, they have problem with epithelial healing, and so we have the various modalities which I'll show. So we look for visual acuity, wound integrity, sutures, AC depth, recurrence of infection, and so on, and secondary glaucoma. So these are some of the representative cases. Some of them are a success, and this is a success. This is a success. Some of them are failures when the infiltrate reaches the edge of the up to the limbus. Even if you do a good job, the infiltrate may always come back and ruin all the hard work. And this is another case where we ended up with a failure. So there is a large list of complications which I'll skip in the interest of time. Epithelial defects, hypopion, recurrence of infection in the graft. And if you are dealing with these cases, then you are bound to have a lot of these problems. What I am going to emphasize now is why is it important that we should see the patients early. This is a 17-year-old girl with history of vegetative matter injury. So typical a fungal corneal ulcer. I did the corneal scraping, filaments. Started with intensive antifungal. Still, she did not respond, and eventually she perforated. Just because she was under my care, I was able to go in and do a therapeutic PKB on an emergency basis, and she had a good visual and anatomical outcome. As compared to this patient, 42-year-old male with refractive corneal ulcer, came from somewhere in the valley, Kashmir. A lot of patients come from Kashmir. Again, a fungal corneal ulcer, but here you see the infiltrate is limbus to limbus. So it has probably invaded, gone all around. So I had no other option to do like a large limbus to limbus freehand dissection and large graft around 13 to 14 mm. The eye was saved, but these grafts don't do well because, for whatever reason, they don't really have their own stem cells. And it was an anatomical success, but not much in terms of the vision. Another patient came from Gurdaspur, 52-year-old male, ulcer for 2 months. Have been to multiple ophthalmologists, most of them well known to me. And anyway, he landed up with me, and he has a large perforation, the iris, and everything is sitting outside, large anterior staphyloma kind of thing, and still a lot of discharge. Once on clearing, you see the iris it's like a big bulb coming out of the eye. So we can't blame the patient for showing up late, but we do our best. So I did a therapeutic PKP. He had a lot of issues. He developed a intumescent cataract. The chamber was very shallow because of the long-standing perforation. The angle and outwing gets distorted. Then I did a TRAV. I did a cataract surgery. The graft failed, and it was not an easy picture. The eye was saved, but visually it was not good. So what we learn here, early referral is the key, as Dr. Sangeeta and Dr. Raman Mittal, they emphasized, because as surgeons, who deal with these kind of cases, we can do a better job if the patient shows up early. So 41 patients. I took up my last 100 cases, 72% were therapeutic, and 26 of them had perforation at presentation. So this is not good. The patient presents late. Obviously, he has a very lower chance of rehabilitation in terms of visual rehabilitation. We try our best to save the eye, but the golden period is already over. It's just then we are going through the motions. So then when I was making this presentation, I sat over and tried to think about various factors. कि patient late क्यों आता है मेरे पास? Late क्यों आता है? So I came up with some of these points which may be added or subtracted. One is factors related to the patient. Patient को ulcer हो गया. Now there is a lack of awareness. उसको पता नहीं कहाँ जाना है. He goes to a village practitioner, उसको steroid दे देता है. He gets worse. फिर वो दूसरे के पास जाता है, तीसरे के पास जाता है, and by the time he comes, he is already perforated for, and he has been to so many people. So at the patient level, there are so many problems. Where to go for the treatment? He goes to he does self-medication, goes to medical stores, and goes to unqualified caregivers. And unfortunately, most of these patients belong to low socioeconomic status. They cannot go to the bigger cities. उनको डर लगता है cities से कि वहाँ जो जाके डॉक्टर लूट लेंगे. And those of us who belong to village will understand that in India there is a lack of access to care where it is needed the most. वहाँ पे ज़रूरत है, वहाँ पे कोई qualified doctor नहीं है. And the villages are related neglected area in terms of prioritization of health care. Then, what are the factors for the primary caregivers? It may be an optometrist, ophthalmic practitioner, or comprehensive ophthalmologist sitting over there. It does not have infrastructure. Lack of infrastructure to treat the eye infection. There is no microbiology. Even in the tertiary institute, there is no microbiology or very poor microbiology services. Empirical treatments, most of ophthalmologists, most of us, we give empirical treatment, antibacteria दे दो, fungal भी दे दो, virus भी दे दो, कुछ ना कुछ तो काम कर जाएगा. But that does not always work. even in the eye care professionals, doctors के पास भी there is lack of awareness where to refer, and then there is reluctance to refer. Some of the top-notch institutes, they have a policy refer नहीं करना जी, अपने आप treat करो, and also then there is competitive spirits. The ophthalmologist, they do not want to refer to the cornea person कि वो cataract भी करता है, और cataract करता तो मैंने उसको refer नहीं करना, मैंने किसी और को करना है. Then never say die spirit कि यार ये एंटीबायोटिक नहीं करी, अब मैं ये चेंज करूंगा, अब मैं ये कर लूंगा, अब ये कर लूंगा, कोई ना कोई तो काम करेगी. It never stops. Some people they just never give up. And on other side there are others who say left to fate कि यार इसका तो कुछ नहीं हो सकता. वो आते हैं, हम कहते हैं कि यार कोशिश करते हैं बचाने की, नहीं कहते डॉक्टर साहब ने बोल रखा कुछ नहीं हो सकता. कुछ नहीं हो सकता जी, ये तो बोले खत्म हो गई आंख. No, that is also a problem we have to deal with. These are some of the points I could come out with myself. Now the surgeon issues जो मुझे होते हैं या मेरे जैसे लोगों को होते हैं. Late presentation, that's the most common. Patient late आता है और all the time that eye is already screwed. And then when he shows up late, he has unrealistic expectation from surgery. कि सर डॉक्टर साहब उन्होंने बोला था जी वहाँ जाओगे उन्होंने आंख बचा लेंगे, आपकी निगाह भी बच जाएगी. And then, because I work in medical college and I work part-time in private practice also, it's very difficult to balance between commercial and non-commercial aspects of the medical care. Because cornea, transplants and everything, it incurs a lot of cost. Dr. Balwinder ने यहाँ पे काफ़ी देर करके देखा है. It's not easy to provide cornea services, transplant services. And because most of these patients are from poor, lower socio-economic status. And then other tissue is non-availability of cornea when it matters the most or in the most urgent situation. And just last year we had in summers, there were no corneas available because summers was walk hoega, ye hoega, and video chalengi. But who will focus on the eye banks? Who will focus on the real thing? We need to have an infrastructure and develop the eye banking at in our state or in the North India, because Delhi se upar north mein koi bhi, there is a Madhav Eye Bank in Karnal, they are doing a good job, but above that we do not have a quality eye bank. And as an organization, I think that is our duty. I would be glad to put in whatever efforts needed from my side to make it possible, but that is what is required. That's what I think. So focus areas include, we need to educate the patient, obviously, teamwork among the eye professional. Remember, we are all here to help the patient, to save his eye, save his vision, and make him see better or help him in whatever way possible. So we need to be more collaborative and especially in such urgent scenario, there is nothing to gain in terms of monetary or other thing. So we need to have a data set of needy patients at the local level, prioritize our resources, optimum utilization of resources, and focus more on eye banking and community level. This is what I highlighted here. Coming back to therapeutic PKP, it is a high-risk procedure demanding high surgical and medical skills. Microbial, obviously we need a lot of good microbial this thing, and with advances in microscopic techniques, new generation antibiotics, we have improved diagnosis. And I'll end my presentation with this girl around in early 20s. She presented with like this from Kashmir Valley. So did a therapeutic, and after 3 years she is 6/12. With some synechiae, but it's good visual, cosmetic, and visual and anatomical and functional success. And these are the kind of the things which keep us motivated and keep us going. So such cases like this. So I would like to thank my senior partner, Dr. Vipin Beg, the eye banks which support us, patients, and post executive, and Dr. Balwinder Jeet Singh for giving me an opportunity. Thank you very much for your attention.
We wish to thank you, Prashar, for speaking from the heart.
Thank you, sir.
ਤੇ ਇੱਕ ਰਹਿੰਦੀ ਕਸਰ ਮੈਂ ਹੋਰ ਸੁਣਾ ਦਿੰਦਾ.
ਹਾਂਜੀ ਸਰ.
ਪਹਿਲਾਂ ਤਾਂ ਮੈਂ ਖਰਾਬ ਕਰਕੇ, ਮੈਂ ਨਹੀਂ, ਮੇਰੇ ਵਰਗੇ ਕਈ ਅੱਖਾਂ ਖਰਾਬ ਕਰਕੇ ਫਿਰ ਤੇਰੇ ਕੋਲ ਭੇਜ ਦੇਣਗੇ, ਫਿਰ ਟੈਲੀਫੋਨ ਕਰਨਗੇ, ਉਹ ਪ੍ਰਾਸ਼ਰ ਇਹਨੂੰ ਰਹਿਤ ਵੀ ਕਰਦੇ, ਉਹ ਰਹਿੰਦੀ ਕਸਰ ਉੱਥੇ ਕੱਢ ਦਿੰਦੇ ਆ. ਤੇ ਇਹ ਵੀ ਹੁਣ ਕਹਿ ਦੇਣਾ ਚਾਹੀਦਾ ਵੀ ਪ੍ਰਾਸ਼ਰ ਤੋਂ ਰਹਿਤ ਨਹੀਂ ਕਿਸੇ ਨੇ ਮੰਗਣੀ ਹੁਣ.
Sir, no, everything works, but I think timely referral is the key. Although obviously because when we do it, we know this is the last thing the patient may be having. कई बारी तो पेशेंट साढ़े को आते हैं कि है ही नहीं जी कुछ कर दो, फिर कर देते हैं कि थोड़ा सा दे जाना यार जब होएगा क्यों हमें भी जरूरत है. बट हाँ जी सर प्लीज. Yes, yes, that's what I need. Sir, I try to.
I suggested so many times to our government that we can make one central either in Ludhiana
Yes,
or
Amritsar.
in Chandigarh or in Patiala or in Amritsar. There should be one state eye bank.
Sir, मैंने SGRD में बड़ी कोशिश की, but actually you know sometimes you hit against the wall your head and you can't do it. Hmm. Sir, let me. Sir, actually, the way I feel it should be done is they do in southern states. उनके ना city में they have an autonomous eye bank as a separate organization. The surgeons are attached to that and they do a wonderful job. Yes. Yes, sir. I think we can have this thing on one of our agenda and try to do it. So it's doable. इसमें बहुत ज़्यादा नहीं है. It's just we need to have the will and you know, it's not infrastructure wise and after some time it becomes self-sustaining. अब तो कर सकते हैं सर. Yeah, we can do it.
करना चाहिए ਹੁਣ ਤਾਂ.
Yes. Definitely. Yes. Yes, sir.
Any queries to Dr. Prasher?
Sir.
Of course, so many wonderful surgeries you have shown.
Sir.
In one surgery, you said large corneal graft with scleral but the fungal case.
Yes, sir.
Because of the lack of limbal stem cells. Have you ever done, or do you think that limbal stem cell transplant from the other side would help in these type of cases? I think that can help.
Sir, in such scenarios, our focus is sometimes that's a doable thing. But actually, we do not have the natural limbus now.
No. What I mean is try it out like we do in OSSN.
Yeah.
There's a huge OSSN. Generally, it's a limbal pathology. The whole of the area is gone. The limbal stem cells are not
Sir,
there,
yeah.
or in chemical or thermal injuries. So we do at the same time when you do the surgical interventions, you take stem cells from the other eye, you transplant the stem cells in this. So that will give you a better chance of survival of your graft. That's my suggestion. You try it out.
Yeah, I haven't done, sir, but yes, a great idea, definitely.
Thank you, Dr. Prasher.
Thank you.
Thank you.
Thank you, sir.
Ladies and gentlemen, last speaker.
कुछ माड़े मोटे बनने लगे जी. So. So this is small video presentation. देखियो ठीक. So this was posterior polar cataract. The patient was explained beforehand about the complication of the and about the second surgery if needed. So first I am making a CCC. Then doing hydrodelineation, no hydrodissection, to separate epinucleus from the central core. and now phacoemulsification. So keeping the bottle height down, low parameters. Generally, I do at 350 pressure and 35 flow rate. So the pressure was reduced to around 200 and flow rate to 20. Slow phacoemulsification. Eating, so the nucleus is out. Now trying to take epinucleus, trying not to disturb the central epinucleus part, which is plugging the defect in the capsule if there is any. I proceed every posterior polar case in this way, presuming that there is a rent, pre-existing opening in the capsule. And important is when you take out a phacoemulsification probe, try not that the chamber should not be flat. So injecting the viscoelastic from the side port before taking out phaco probe. So this trying a viscodissection, injecting the viscoelastic underneath the capsule, between the capsule and epinucleus. So here one mistake I made was I injected too much viscoelastic. So again doing viscodissection and trying to plug the trying to push viscoelastic so that it can plug the posterior hole in the capsule. Now dislodging the sub-incisional epinucleus so that it can be taken out easily with the phaco probe. So taking out the epinucleus. See, now you can see this part. This here is the probably this was the rent, pre-existing rent, but here this is a tear in the capsule. Now taking out cortical matter. So again pushing the viscoelastic so that the vitreous should not come forward. So now you can appreciate this. The rent is so large in the posterior capsule, but the use of viscoelastic prevented the vitreous from coming forward. This is IOL injection 3-piece in the sulcus. So the important thing is that try every time you come out, you take out the phaco probe, you inject the viscoelastic so that the chamber AC should not be flat. So this, before taking out the viscoelastic, I hydrated the main port and side ports. Again, to ensure that chamber becomes less flat. Now taking out the viscoelastic. So even if some amount of viscoelastic is left in the chamber, it gets absorbed in 1 or 2 days, and there is not much rise in pressure. Because rent was too large, so I didn't. And because rent was too large, so I didn't. And the second thing, sometimes you try to push in the it can extend the rent in the posterior capsule.
If you had used bimanual, it would have been a very easy and fast.
Yes, sir.
I have done 2 cases. I would say only seen 2 cases in my life with the pre-existing this type of end.
Yes,
What
yes.
you are extended, but mine was pre-existing. Before surgery, before you could see the rent, I have.
Yes, sir.
I removed slowly and slowly all the layers with bimanual, and the rent did not. Rent had thickened edges.
Okay, sir.
So I removed with bimanual and put the lens in the bag.
Yes, sir. Bimanual is always better. I have not used bimanual. I have never tried bimanual.
That's strange because bimanual is even bimanual deconvulsivation in such cases is very important.
Okay.
We used to do.
Yes, sir.
Over deconit and all that. That's bimanual.
Yes, yes.
That is also because you can approach all this segment area.
You can approach every area. Yes. Yes, sir. Yes. I have seen your case, seeing you doing bimanual phacoemulsification at your center also.
With anterior OCT, I think you can just make out pre-existing rent also.
Yes,
if you
sir.
have anterior OCT.
Yes, sir.
Some people are having, I'm not having, but you can, before surgery, you can come to know there is a
You can come to know the
pre-existing,
posterior.
yes. It's very costly, I think it's 40 lakhs or something.
I thanks Dr. Sangha for conducting this session. Now I request Madam Paura and Dr. Mitra to come forward to honor the speakers. I will request Dr. Gurvinder Kaur. Sir, आ जाओ. Sir, आओ please. Dr. Pora, please. Sir, आओ जी please. Dr. Raman Mittal. I will request Dr. Manpreet Kaur to join for honoring the speakers. Dr. Manpreet, please. Madam, Dr. Action. नहीं करना सर है गया. Dr. Manpreet, please. So, मैं भी आ जाना जी. ये दोबारा हाँ जी लो जी
एबी
V for VIE.
Okay. Ladies and gentlemen, I know that you are hungry. I know that you are in a hurry to go. But the last event of, every function is the vote of thanks. So I have been given the privilege to pass the vote of thanks. I, first and foremost, I thank the Punjab Ophthalmological Society, ਜਿਨ੍ਹਾਂ ਨੇ ਕਿ ਵਿਦਿਆ ਘਰ ਘਰ ਪ੍ਰੋਗਰਾਮ ਜਿਹੜਾ ਉਹ ਸ਼ੁਰੂ ਕੀਤਾ ਹੈ ਤੇ ਉਹਨਾਂ ਨੇ ਲੋਕਲ ਜਿਹੜੀਆਂ ਆਪਥਲਮੋਲੋਜੀਕਲ ਸੁਸਾਇਟੀਜ਼ ਆ ਉਹਨਾਂ ਨਾਲ ਮਿਲ ਕੇ ਮੰਥਲੀ ਮੀਟਿੰਗ ਜਿਹੜੀ ਆ ਉਹ ਡਿਫਰੈਂਟ ਜਗ੍ਹਾ 'ਤੇ ਜਾ ਕੇ ਕਰਨ ਦਾ ਫੈਸਲਾ ਲਿਆ. ਇਹ ਸਭ ਤੋਂ ਵੱਡਾ ਸਟੈਪ ਹੈ ਕਿ ਵੀ ਉੱਥੇ ਜਿਹੜੇ ਲੋਕ ਨਹੀਂ ਵੀ ਕਿਤੇ ਪਹੁੰਚ ਸਕਦੇ ਉਹਨਾਂ ਨੂੰ ਉੱਥੇ academic feast ਜੋ ਅੱਜ ਮਿਲੀ ਹੈ. I think you will be satisfied with this. And the Punjab Ophthalmological Society, they need an applause for this action ਕਿ ਘਰ ਵਿੱਦਿਆ ਜਿਹੜੀ ਹੈ academic feast ਜਿਹੜੀ ਨੂੰ ਪਹੁੰਚਾਉਣੀ ਹੈ. The second is the Doaba Ophthalmological Society, those who have taken this initiative to hold this first meeting of the year in Hoshiarpur. I think the all credit goes to the hero of Hoshiarpur, Dr. Balwinder ji, who takes all the burden on his two shoulders. He has so strong shoulders that he takes all the load on his two shoulders to arrange. And you must have seen the arrangements. They are so perfect that he also needs an applause. Thirdly, I think without money the mayor will not run. You all agree with this, and I thank the company ABVY who sponsored this meet, and all the arrangements, all they have been made by this company. We are thankful to them. I have got one suggestion for them and the future companies, who hold. I was seeing that the local faculty was less than the guest facility. That was my observation, and I request the companies who are sponsoring this that they should put in more efforts to mobilize the local, members, that so that they should come in time and have the chance to listen. And regarding the iBank, it's my earnest opinion, Sir Dr. Karmjit, it's for you. I think the iBank, why can't it be started by the Punjab Ophthalmological Society? It does not involve so much large funds that we can't have a model iBank at Jalandhar in a private sector. And that can be sponsored by the Punjab Ophthalmological Society. Every doctor of the state can contribute to that, or there can be some model, but I think the Punjab Ophthalmology Society should take a lead for this and set an example for other states that look, we are running this model iBank here and you have to run. I think once you start, the money will not be a problem. We wish to honor the sponsors, ABBY. It's a difficult name, ABBY. Abby. We can call it Abby. Please come forward and I request Dr. Pora, the president of POS, and the secretary, and Dr. Balbinder, and all to honor them, because as I said, the mayor cannot run without money. मेरी भी यार नाल खिंच रही हो। Thank you all. Enjoy the hospitality of Hoshiarpur. Thank you very much.
I will also like to thank Khamba Studio, Mr. Parminder Singh, for recording it beautifully. In the last meeting also, he recorded and he made video so well, and it was appreciated by all over Punjab. Thank you.
Dear friends, At the end, I would like to really appreciate the efforts of Dr. Balwinder Singh and Doaba Ophthalmological Society. He is a wonderful guy, a wonderful friend, and he has shown that ਸਿਟੀ ਦਾ ਸਾਈਜ਼ ਮੈਟਰ ਨਹੀਂ ਕਰਦਾ, ਦਿਲ ਦੇ ਵਿੱਚ ਨਾ ਤਮੰਨਾ ਹੋਣੀ ਚਾਹੀਦੀ ਹੈ ਕਿ ਤੁਸੀਂ ਕੁਝ ਕਰੋ, ਤਾਂ ਉਹਨੇ ਕਰਕੇ ਦਿਖਾਇਆ ਕਿ ਸਿੰਗਲ ਹੈਂਡਡਲੀ ਤੁਸੀਂ ਵਧੀਆ ਤੋਂ ਵਧੀਆ ਕੰਮ ਕਰ ਸਕਦੇ ਨੇ। ਸਾਰੇ ਪਛਾੜਤੇ, ਅੰਮ੍ਰਿਤਸਰ, ਜਲੰਧਰ, ਲੁਧਿਆਣਾ ਸਾਰੇ ਪਛਾੜਤੇ ਹੈਗੇ ਆ। ਦੋਬਾ ਵਾਲੇ ਨੇ ਕਿਹਾ ਤਾਂ ਕਿ ਅਸੀਂ ਸਭ ਤੋਂ ਅੱਗੇ ਗਏ ਹਾਂ, ਤੁਸੀਂ ਸਾਨੂੰ ਫੜ ਕੇ ਦਿਖਾਓ। ਡਾਕਟਰ ਮਿੱਤਰਾ, ਡਾਕਟਰ ਕੁਲਦੀਪ ਸਿੰਘ ਇਹਦੀ ਬੈਕਬੋਨ ਹੈਗੇ ਨੇ, ਡਾਕਟਰ ਰਾਜਨ ਸਰਬਜੀਤ ਵਗੈਰਾ ਸਭ ਦੇ ਸਾਥੀ ਨੇ, ਪਰ ਇਹਨੇ ਬਹੁਤ ਵਧੀਆ, ਇਹਨਾਂ ਨੇ ਬਹੁਤ ਵਧੀਆ show ਕੀਤਾ। They were the last to enter into the POS, but they are the forerunners. I really appreciate Dr. Balwinder Jeet and Dr. Mitra and their colleagues in Doaba Ophthalmological Society. And I really thank AbbVie people. They are always in support to any organization who wants to do academic activities. Wonderful.
Thank you. Thank you, Dr.